Good morning, everyone, and welcome to the Johns Hopkins Bloomberg Center. I am Dr. Roland J. Thorpe, Jr. I am the Associate Vice Provost for Faculty Diversity and a professor at the Bloomberg School of Public Health. I am absolutely excited about our time that we're going to spend together today. This is the first of a series of events that we will have from the Health Opportunities for Policy Equity, or what we affectionately call it, the HOPE Challenge. We're excited about we're excited about today's panel that we're going to have. And I just want to first start off by saying we appreciate the generous support from the Nexus Award from Johns Hopkins University. And I also want to start out by appreciating all the people who have worked behind the scenes to bring us to where we are today. So I really wanted to acknowledge them right now. So we'll start this morning event with a welcome from the leaders of the two of the four coordinating partners for today's events. Our partners are the Congressional Black Caucus Foundation, Congressional Hispanic Caucus Institute, and NMAC. First up, we'll hear from my good friend, Dr. Darrell Gaskin, who is the William C. and Nancy F. Richardson Professor at the Bloomberg School of Public Health, and he also directs the Hopkins Center for the Health Disparities Solutions. Dr. Gaskin is a health economist who advances community, neighborhood, and market-level policies and programs that reduce health disparities and move us toward achieving health equity. He will then be followed by Mr. Paul Kawada, the Executive Director of NMAC, a nonprofit that seeks to normalize discussions about race in the HIV movement while fighting for health equity and racial justice in America. Founded in 1987, the NMAC is working to bend the curve of new HIV diagnosis while ensuring those who are living with HIV receive the ongoing care they need. As Executive Director, Paul works with his board and staff to set the strategic direction for NMAC and oversee its training, technical assistance, and advocacy programs. Additionally, Paul conceived and developed many of the organization's high-profile meetings, including the United States Congress on AIDS, which is currently the largest annual AIDS-related gathering in the country. Let's give a warm round of applause for Dr. Gaskin and Paul Kawada.
So thank you, Roland, for that very kind introduction. And good morning, everyone, and welcome to a gathering that all about making a difference. The inaugural Health Opportunities and Policy Equity Challenge Breakfast Forum. I couldn't be more thrilled to kick off our first Hope Challenge with you, and then on this very special day, which is World AIDS Day. Today, we're going to be diving into a topic that not just relevant, but is also timely. HIV and the politics of race, the Minority AIDS Initiative at 25. This gathering isn't just presentations and stimulating conversation, but more importantly, it's a call to action. So fasten your seatbelts, because we're embarking on a journey to really try to change lives. At the heart of the Hope Challenge mission is a clear and compelling desire and need to create a brighter and healthier and more equitable future for all. We're talking about improving national prosperity, cutting down healthcare costs, ensuring that everyone enjoys good health and thriving communities. How? By leveraging the power of public policy to eliminate those glaring racial and ethnic health disparities that shouldn't exist in our society. Now, let me be plain. We've got a problem on our hands. Too many people suffer from preventable health conditions. And this is not just a national health crisis, it's a national economic crisis too. It's literally dragging down our nation's standard of living. Preventable health conditions are robbing us of precious years, dampening our productivity, and adding unnecessary and excessive healthcare costs. Unfortunately, the brunt of this burden falls disproportionately on our fellow citizens who identify as African American, Hispanic, Native American, Alaskan Natives, Asian American, Pacific Islanders, and the LGBTQIA+ community. However, there's good news. We're not just here to lament the problems. We're here to talk about solutions. This is why the Johns Hopkins Center for Health Disparity Solutions, along with our partners, the National Minority AIDS Council, the Congressional Black Caucus Foundation, the Congressional Hispanic Caucus Institute, have convened this gathering today. I want to thank the Johns Hopkins University Nexus Award Program and the William C. and Nancy F. Richardson Professorship for their generous support of the Hope Challenge Breakfast Forum here at the Johns Hopkins Bloomberg University, Johns Hopkins Bloomberg Center. Our goal is to shine a spotlight on the 25th anniversary of the Minority AIDS Initiative, a policy intervention that was way ahead of its time, thanks to Congresswoman Maxine Waters, who championed it into existence in 1998. A health equity policy before the term health equity was in vogue. The Minority AIDS Initiative was sought to address HIV disparities in communities of color. Today, we're going to dissect its impact and figure out how we can supercharge it and other policies so that we can finally end HIV disparities. But that's not all. We have something extra special in store for you. We have CNN commentator and political insider Jamal Simmons, who will lead a fireside chat with some of our nation's legal whizzes. The chat will dive headfirst into the anti-woke movement, what it's all about, and what it means for our mission. Plus, we'll be unpacking the Supreme Court's recent decisions on affirmative action and other legal maneuvers that seek to block interventions aimed at closing those stubborn gaps in health, wealth, and education. The best part, we're going to lift up potential policy solutions that may safeguard the future of these critical health equity interventions. This is about health equity. I am reminded of a poem by Langston Hughes, I Too. I too sing America. I am the darker brother. They send me to eat in the kitchen when company comes. But I laugh and eat well and grow strong. Tomorrow I'll be at the table when company comes. Nobody'll dare say to me, eat in the kitchen. Then, besides, they'll see how beautiful I am and be ashamed. I too am America. Health equity recognizes that all of us have a right to sit at the American table and enjoy life, liberty, and the pursuit of happiness. Health equity insists that our society implement policies and programs in such a way that everyone has a low risk of contracting HIV, and if some do, they can live long, healthy, and productive life. Unfortunately, our initial efforts to halt the transition of the disease and to care for people living with HIV were not benefiting everyone. Racial and ethnic minority communities were being left behind. The Minority AIDS Initiative introduced the concept of health equity in the nation's effort to address HIV/AIDS pandemic. Asking our decision makers to incorporate health equity in their policies and programs is merely asking them to follow the golden rule: do unto others as you would have them do unto you. In other words, treat no one as though they deserve less than you and those in your community. And even if you perceive someone as the other, make sure your policies and programs are as effective for them as they are for you. The golden rule standard in our policies and programs insist that our policies and programs be effective for all of us. So welcome your brothers and sisters to the American table, because they too sing America. So sit back, or don't just sit there though. Be ready to engage, share your brilliance, and help us pave the way towards a society where everyone, regardless of their background, gets a fair shot at being healthy and living a prosperous life. Today, I want to thank you all for being here for this World's AIDS Day, and together we'll turn the tide on disparities and make health equity a reality. I'm now pleased to turn it over to our event partner, Paul Kawada, the Executive Director of the National Minority AIDS Council, to bring welcome remarks.
It is World AIDS Day today. I moved to Washington in 1985 to fight an epidemic that was killing people that I loved. In 1989, I became the executive director of a small national minority organization here in Washington, D.C., called the National Minority AIDS Council. I have been the ED for 34 years. It's probably older than many of the students sitting in this room, and so I just want you to know how glad I am to see you all here. I want to start by thanking Hopkins University. Look at this beautiful space we're in. I mean, I have to tell you, when we first started this work, organizations like mine would never be invited into beautiful spaces like this. And so it is such an honor and a privilege to be standing in front of you in this extraordinary space. I want to thank Dr. Rocky Cummings for getting us here. Look at this. Look at this for a second. Black Caucus, Congressional Hispanic Caucus, and NMAC. One of these things is not like the other, folks. And I want you to know that I know that. And I know that it takes friends to open the doors to get us into these rooms. That these are not rooms that we often get invited to, and so I am so appreciative. And I am particularly appreciative of the Congressional Black Caucus and the Congressional Hispanic Caucus. Last night, we did an event on the Hill honoring all of the women of the Congressional Black Caucus. And we had 17 members of the House and the brand new senator from California there joining us. And it was one of those moments where I had to pinch myself, because I remember a time when people would shut their doors and not meet with us when we went on the Hill. I remember a time when people were afraid to shake my hand. I remember a time when I would sit at hospital beds screaming at God about how unfair this is. And I share that story with you because right now it feels really similar. I have to tell you, the world is crazy. The world is crazy. And we are sitting in a moment in history that is almost impossible to define, because people don't want to believe the science. People don't want to believe the truth. People don't want to talk about solutions. They want to talk about stupidness that has nothing to do with the reality of where we are in a world. To all the students here, I worry for you. I have to tell you, your future, that's why this Bloomberg program is so important, because you are the future. You're going to have to take this battle to the people. You're going to have to fight for equality and justice, because we live in a world right now where the Minority AIDS Initiative was almost defunded 2 weeks ago in the House. after 25 years, there was a vote they took away almost all the money except for the last $25 million. And then there was a final vote to get rid of that. And you know what? In this crazy house, we won. We had enough Republican members stand with us and say that you are not going to get rid of the last of the money. And so even in this, I wanted to bring you some hope. I wanted you to know that our voices matter. Our issues matter. We are part of a generation of people who are having to fight the last vestiges of a system that was set up for us, not for us. We are fighting the last vestiges of a world that says, there are literally people who say we're not good enough just because of the color of our skin, just because of who we love, just because of the way we choose to express our gender. But hopefully, we will fight and win. And so thank you for being here. Thank you for being a part of this extraordinary moment in history. Because I want you to know there's an old ACT UP saying that we're going to fight like hell for the living. And I need you all to fight like hell for the living because there has never been as much at risk as there is right now. Thank you for being here.
Thank you for those inspiring, welcoming remarks. It's now time for our panel, HIV and the Politics of Race, to begin. Can the panelists please come to the stage and take their seats? While they're doing so, it's my pleasure to introduce to you the panel's moderator, Dr. Maya Rockeymoore Cummings, who is a visiting scholar at the Johns Hopkins University, Bloomberg School, and the Department of Health Policy and Management, a widely known commentator, activist, and strategist. She is also the founder, president, and CEO of Global Policy Solutions, a social change strategy firm that seeks to drive society toward inclusion. Maya, take it away.
Good morning. Thank you, Roland, for that gracious introduction, and thank you to Dr. Gaskin and Paul Kawada for those inspiring remarks. And I thank every single one of you today who is joining us either in person, on C-SPAN, or on our live stream for this very, very, very important World AIDS Day event. With that, I should just say that we're here to talk about HIV and the politics of race, the Minority AIDS Initiative at 25. Now, I should tell you that back in 1998, when I was just a very, very, very young person, I won't tell you how old, I came to Washington to find out what the Congressional Black Caucus was doing around HIV. In the news, there were more basically published accounts about the disparities, the racial and ethnic disparities that were happening with HIV/AIDS in communities of color. And there had been, theretofore, no federal policy response that addressed the issue of the disparities. And I arrived just in time to witness a phenomenal, I think, occurrence. I arrived just in time to see HIV/AIDS leaders, activists, organizational leaders, and certainly administrators from across the country, they were all of color, come to Washington to appeal to the Congressional Black Caucus to do something. They were not receiving the monies needed in order to address the epidemic in their communities, and they were very concerned. Prior to that, the Ryan White CARE Act had been the primary funding mechanism for HIV funding for community-based organizations around the country. And they were complaining that the money wasn't getting to them because of how the politics of how the money was actually being controlled through the Ryan White CARE Act. They appealed to the Congressional Black Caucus to basically do something by creating a funding stream that went directly to community-based organizations led by people of color who were working in and serving people of color. The chair of the Congressional Black Caucus at that time, Congresswoman Maxine Waters. And she carried that ball like nobody's business. She literally caught the ball. They tossed it, she caught it, and she ran with it. And she was able to create the Minority AIDS Initiative. The other caucuses, the Hispanic, Congressional Hispanic Caucus, Congressional Native American Caucus, Congressional Asian American Caucus, all of these caucuses got on board to support this initiative. Unfortunately, I should just say that in around the early 2000s, the administration of George W. Bush decided that they would no longer adhere to the guidance that the monies go directly to minority-led organizations. That meaning that any organization could get the monies. And so here we are today, 25 years later. Health disparities on HIV are huge and growing. And we have a problem, but we must fix it and move forward to save lives. And so with that, I am delighted to have a wonderful and distinguished panel of leaders to have this conversation today. People who have been in the trenches for a very long time doing this work like you just wouldn't believe. And so with that, my very first person to my left is Mr. Guillermo Chacon. He heads the Latino Commission on AIDS, and he is just a wonderful person. I have seen him as an activist. He is brilliant, he is passionate, and he cares. He comes from a community-based perspective, having worked with organizations in the field for a very long time. So I want you actually to set the context for us. Where are we right now, and how did we get here? And what has been the conditions on the ground with regards to HIV/AIDS? Guillermo.
Thank you, everyone. Thank you, Maya, for your introduction. And in the opening also, I think it's important to pause as the global community recognized World AIDS Day to date. We need to also remember the huge human costs, all the lives that have been taken from us from HIV. And I truly believe that pausing here and analyzing 25 years later and answering the question of Maya, we have a problem. We have a huge problem. If you review the latest data by the Centers of Disease Control 2021, it's a consistent impact among Black, Latinos, Asians, Native, and people say to me, but it's not a lot about Native. I say, one infection of HIV is enough for all of us because it's 100% preventable. It has to be, from a public health perspective, sound the alarms. But Black and Latinos, we Latinos used to be the third most impacted, we're the second most impacted. And all related about resources. I always told people that the intention and the amazing visionary vision of the leadership led by Congresswoman Maxine Waters, that is still being the voice of the voiceless, and remind that what will be the right thing as a members of Congress to shape resources for those dealing with health issues and health disparities, and HIV in particular, is what really has to be paused, analyzed, and recheck the will. Paul reminds us about how difficult is the moment that we're living right now. But I always told people, when you look historically in the US, are always cycles that remind all of us of the opening beautiful point to be at the table. And we believe that if you empower and provide resources for community-based organizations that are reflecting those communities most impacted, we will be able to shape and bring a unique perspective, community trust, that is the highest currency to connect and to address a very complex issue as HIV is. And people say to me, why we don't have a vaccine? Why we don't have a cure? People working around the clock for those issues. But as right now, over 30,000 new infections, it reminds us that we can do better. And also, when we think about the 50 states, we need to think about the territories, especially Puerto Rico and the U.S. Virgin Islands. And I remind folks, in the U.S. Virgin Islands is 20% more or less of immigrants and migrants that go and work from different industries that are not in nobody's radar in terms of delivering awareness and support services and testing as the key element to identify and to prevent the spread. And then, Maya, I really want to challenge all of us, and the thing, I think, capture the call to action for all of us to really bring back the original intent of the 1998 Minority AIDS Initiative to put one particular set of funding dedicated to the organizations that represent those most impacted. And one key element that I always remind folks is strengthening, especially the internal infrastructure, because I'm a big proponent of public and private, but also community partnerships. When we work together, we can make the difference, and I think that's the challenge for our panel and the whole program today. Thank you, Maya.
Thank you. Thank you, Guillermo. Dr. Robin Neblett Fanfare she is the interim director of the HIV and Infectious Disease Unit at the Centers for Disease Control and Prevention in Atlanta. And so we are delighted to have her here, not just as the head of this very important agency subunit, but also as a Johns Hopkins University Bloomberg School of Health graduate. They're everywhere. And so, Dr. Neblett Fanfare, we would love to hear from an insider's perspective how the CDC is actually using the Minority AIDS Initiative dollars, and also at what particular communities and what kind of innovative techniques and approaches are you using to address this, and particularly in disproportionately affected communities.
Would you mind if I stood up there?
Not at all.
Y'all know I'm from CDC, so I have to have a few slides. Spare me. And thank you so much for the warm welcome. It truly does feel like a homecoming. Hopkins and Baltimore specifically is really where my love of public health, HIV, and health disparities was first nurtured and supported. So it truly means so much for me to be here today. So like Hope's mission, at CDC, we're really focused on closing preventable racial and ethnic health disparities. And anytime I talk about disparities, I think it's so critical that we start with the reason why these disparities exist. We have to frame it before we even start to talk about disparities. Though these disparities exist because of the impact of systemic factors and longstanding inequities, starting with racism, starting with white supremacy, the impact of homophobia, transphobia, stigma, residential segregation, economic marginalization, and mass incarceration all significantly lead to what we are seeing, the disparities I will present now. HIV incidence is higher among same-gender loving men, Black people, Hispanic people, and women of transgender experience. I know we will hear about it more from the panel, but the biggest gaps that we see in pre-exposure prophylaxis coverage are among Black and Hispanic people. There are more HIV outbreaks among people who inject drugs. The southern United States has higher rates of HIV than other regions, and viral suppression is lower among American Indian, Alaska Native, and Black people. These disparities are severe and unacceptable. So let's talk a little bit about what we're doing at CDC with a specific focus today on Black, cis, and transgender women and Black and Hispanic same-gender loving men. So for women, what are we doing for PrEP? PrEP, as we know, is highly effective to prevent HIV, about 99% when taken as prescribed. But our preliminary data from 2022 shows that while more than 40% of males who could benefit from PrEP were prescribed it, only 15% of females were, and only 13% of Black people eligible for PrEP were prescribed it. So let's talk a little bit about what we're doing. First, there's the Let's Stop HIV Together campaign, which is a national campaign to help end the HIV epidemic. So in 2021, we started #She'sWell, PrEP for Women, which is focused on increasing awareness about PrEP among women, building capacity among clinicians to prescribe PrEP, and eliminating PrEP disparities that we see. This #She'sWell was an initiative created for and by Black women to ensure that Black women see themselves in the messaging, which adds to the impact. Our portfolio also includes Together Take Me Home. If you have not heard about it, please Google it, Together Take Me Home. You can go and get a free HIV self-test kit that's delivered to your home. And what we've seen is the first 8 months of this program, over 300,000 HIV self-test kits have been ordered. In September of this year, we launched Her PrEP, looking to increase PrEP among Black women in the U.S. The purpose of this 4-year study is to evaluate the effectiveness and implementation strategies and increase PrEP use among Black women where they're already seeking care, in particular at primary care, sexual, and reproductive care clinics. And then transgender women involved in strategies for transformation or twist. This is an intervention written for and by women of trans experience, which aims to increase sexual health knowledge and build self-efficacy to make decisions based on personal values and goals. Another population disproportionately impacted by HIV due to these longstanding inequities and social determinants of health are our Black and Latino same-gender loving men. To combat these disparities at CDC, we're funding research to look at the drivers of medical mistrust, in particular in Hispanic and Latino populations, with a special attention to same-gender loving men. We are funding, as Guillermo so eloquently said, community-based organizations that are trusted messengers and are in the community and directly serving same-gender loving men of color and young transgender persons of color and their partners. And then finally, with Together Take Me Home, I talk about that 300,000. More than 60% of the HIV self-test kits have been ordered by same-gender loving men. So in closing, I just want to say a sincere thank you to all of you. This is one of the equity and social justice issues of our time. I stand here on the shoulders of so many Black, brown, LGBT communities, people living with HIV, advocates, activists, clinicians who have done this work to get us to this point where we can actually say we can end the epidemic. But we have to make sure that when we get to the finish line, we are all there together. Thank you.
Thank you, Dr. Fanfare. That's awesome. Excellent. Next, we have Dr. Joshua Sharfstein. Now, he is at the Bloomberg School also of Public Health at Johns Hopkins University. But I know him from way back. He was the head of the Baltimore City Health Department for a long time. And he also led basically the State Department of Health as well. And he was a good friend of my late husband. And so with that, Dr. Josh Sharfstein. Mm-hmm.
Thank you so much, Maya. It's great to be here on World AIDS Day. Thanks so much to all the centers and programs that have sponsored today. And I also want to say Dr. Fanfare was a Baltimore City Health Department leader as well. So it's great to be here. I've got just a couple slides here. And I'm going to talk about something maybe a little bit different, which is the importance of overcoming inequities in the healthcare system in order to make critical progress on HIV. And Dr. Fanfare mentioned some of this, but this is the latest data from CDC. It's just worth looking at for a second here. I mean, there are many inequities in health and healthcare. This is one of the particularly staggering ones. In the last data, 78% of white Americans who could benefit from PrEP received it, but it was only 11% of Black African Americans. That is, and 21% of Hispanic Latino Americans. Just an enormous gap in access to pre-exposure prophylaxis, a medical intervention. Don't want to imply that medical interventions are the only thing, but it is no coincidence that more than 2/3 of new infections are among Black and Hispanic Americans. The latest preliminary data from 2022 shows that that gap has actually grown larger, and it illustrates something that's important to understand. A great medical advance can translate into more inequity if it goes through the prism of an inequitable healthcare system. When people don't have access to care, then the people who can get it get helped, and the people who can't get it don't get helped. And this is, I think, one of the stories of HIV, and now is a story of PrEP. So what is keeping people from PrEP? And there are a bunch of different reasons. I'm going to talk about the first one, inadequate access, but I don't want to imply it's the only one. There is certainly the issue of competing concerns, social factors, the way that racism and homophobia express themselves, inadequate knowledge about PrEP, which the CDC is working on through those great campaigns, and other reasons. But I want to talk about the first one, just getting access to medications. And that's why my focus is on the healthcare system as the prism for generating inequity. You heard that most of the gap in HIV, or a huge chunk of it, is in the South. And it is no coincidence that many states in the South have not expanded access to Medicaid, and many people don't have insurance. And so what happens if you're uninsured and you want to get a medicine that requires lab tests in order to prevent HIV infection? And as Dr. Pfanfer said, 99% for sexual contact prevention. And you don't have to read this chart, but it's confusing. You know, we could have done a flow chart, which would have been even more confusing. But basically, you have to fill out a lot of paperwork. It's very hard to get. I spoke to one woman who's doing phenomenal work in Arkansas, teaching people about PrEP, and I said, how's it going? She goes, it's great. At the end, everyone wants PrEP. There's only one problem. Nobody can get the PrEP. You know, there's a phone number they're supposed to call. Nobody ever picks it up in the state. We did, Derek Dangerfield from the School of Nursing did some focus groups as we were working on PrEP, and talked to someone who said, it's kind of expensive for a disease I don't have. In other words, you have to make PrEP easy for people. It is like a vaccine, right? It works 99% of the time for sexual contact, 75% for IV drug use, but you got to make it easy. And if you think about the progress that was made in many communities on the COVID vaccine, is because it was made easy. But if people have to fill out monthly paperwork and pay for labs out of pocket, you cannot be surprised when there's huge inequities in access. And so the solution that I will humbly submit here is to cut through the complexity. We cannot rely on the infrastructure of an inequitable healthcare system to close these staggering and growing gaps in access. And I have worked with many people, many in this room, on putting forward the idea of a PrEP program that would make it much easier for people to get PrEP. You could go to the pharmacy and get it from a pharmacist. It would take advantage of very low-priced generic PrEP. There would be free laboratory tests. This is kind of, you know, for people who just lived through the pandemic, it just like what we tried to do for COVID, go in anywhere, get a test, go in anywhere, get a vaccine. We'll partner with community organizations to get people testing and vaccines directly. That's the kind of PrEP program that's necessary. The critical role for trusted community organizations like those supported by the Minority AIDS Initiative, and some opportunities for CDC to begin work on this by having pilots that just focus on making PrEP accessible. If, you know, there is education alone without the access is not a recipe for success. Here are a couple sites to learn more about this. I appreciate the chance to talk about it. I think this is a major opportunity to kind of move into the future and tackle the healthcare system inequities directly for greater progress on HIV. Thank you.
Thank you, Dr. Sharfstein. And last but not least, we have Joe Huang Recalto. He is the Director of Policy at NMAC, and I have had the pleasure of working with Joe over the past year and a half. He is a passionate and compassionate leader. He gets what's happening on Capitol Hill and why it's happening, and he's going to give us a sense today of the landscape in terms of what's happening on the House side and the Senate side and what's likely to happen with regards to funding and why. Explain why, Joe.
Yeah. Yeah, no, thank you. Thank you, Doctor. Yeah, it's $1 million question. I do want to say, first, thank you to Dr. Cummings. I don't know how many of you know this, but she wrote her PhD dissertation on the MAI. And it's in large part with her, obviously, background with Congresswoman Waters and the CBC, where she was also the executive director, that we got as far as we did with the MAI because of your kind of drive there. It was about a year ago, I guess about a year and a half ago, where folks here at NMAC, we thought there may be some trouble with the MAI regarding funding. And what we did is we put together a group to try to, when Dr. Put the stats up there and we see this huge gap in disparity, that's a huge red flag for us because the money's not getting, the MAI funds are not getting, in our opinion, to the organizations and to the communities that need the funding. The MAI, over the years, has morphed into, I think, over about $425 million. I think that was our latest target anyways. Maxine has always wanted to get it over $600 million, and we're still going to chug at that. But the politics is now getting in the way, and it's going to kill people because these numbers, particularly with PrEP and folks that can't get PrEP, are going to be suffering the most. So the communities that need it the most, right, are not going to get it, and it's going to be exasperated by the politics of this. I remember I retired from the Hill in 2017, and my first boss was then Senator Kennedy, Ted Kennedy. And when we wrote, when they did the Ryan White Care Act, we saw that the minority communities needed their own separate funding. Fast forward to NMAC, right? We try to unpack the MAI. And remarkably, what we wanted, the goal here was to get the money from minority, let me get this right here, minority serving organizations back to what we thought was the original intent of minority-led organizations. And there's quite a big difference there, right? So we brought Maya on to help us lead this charge, and we put together Tony Newman, who is interim executive director at BAI, Black AIDS Institute. Guillermo was on the team. And what we found out, and we worked with with Maxine's office, what we found out was that there was no statutory funding attached to it, right? We said the original intent was minority-led organizations. That was the belief for 25 years. And what we found out was there's really no hardened language that says that. So we were kind of, I think, struggling, if you will, to identify a fix to this, right? Because we knew, and so what we did, we were successful in doing this last year. What we did is we were able to get report language into the Labor H bill, which directed the secretary to identify ways to bring the money, the MAI fund, back to its original intent. Then the politics got worse because the Dobbs decision came out, and the affirmative action was being argued in front of the Supreme Court. So we were successful in getting the language, but enforcing the language was another ball of wax, right? So we met with, and Maya was there, we met with Maxine's office, and she was quite furious. And if you know Maxine, you kind of don't want to be on her bad side at any given point, right? So we argued our case in front of Becerra, Secretary Becerra, and the decision was ultimately made to hit pause and not rattle this because of the affirmative action case, which it did ultimately come out the way we thought it was going to come out. That targeted schools. What's to stop them to going after health funding, targeted funding for minority communities, et cetera. So it was a very dangerous kind of area for us to be in. So we did hit pause. And we are going to wait, and of course the House flipped. We're going to wait and try to keep our foot on the gas to get the funding reinstated, right? I say reinstated because we're not quite, Labor H is still out there. So if they do fund, cut it, we're going to work obviously with the Senate to keep the funding in there. Lord knows with this current political climate on the House side, how this is going to fall out. Understanding this, that they completely eliminated the EHE, the ending the HIV epidemic line, completely eliminated that funding. Yeah. So ending the HIV epidemic is what Congress, and actually it was former President Trump that kind of got the money going there. It was in essence a funding initiative to get PrEP into the communities where they needed it most. We were successful in getting an increase in that EHE funding line. This Congress zeroed it out. And that's interesting because when we were on the Hill, and I say we, I see Jesse from AIDS United here, when the coalition members, our coalition partners were on the Hill, that was our in to the GOP offices. Hey, this was a Trump initiative, right? You don't want to take out former President Trump's program. President Biden doubled down to ending the epidemic by, I think, 2030. But to have this kind of Congress that zeroed out a Trump program is highly unusual. And then we started digging deeper, and we know that is obviously more than the EHE. The MAI, I believe it was cut to the tune of $375 million, right down to nothing, which will exacerbate the problem even more so. So we saw all the funding lines within HIV kind of zeroed out or darn near zeroed out. And that's very dangerous because we're at a point here in this country where we really earnestly believe we can stop or get as close to stopping the transmission of HIV as possible. Now is not the time, obviously, to take away the funding. Now is time to double down. The politics of this is very dangerous, though, and I want to kind of emphasize we're in a very unknown territory, particularly with HIV funding. And sometimes I think I've always thought that two things drive advocacy: anger, and anger is number one. And I'm going to talk, maybe not here, but we do have some webinars planned at NMAC where we will talk about the anger within the communities that are being decimated. I'll stop there, Maya, but I do want to kind of just emphasize that MAI funds are...
That's a good segue because I'm going to come back this way. And that is, to be clear, the House of Representatives, the Congress is bicameral, so Senate and U.S. House of Representatives, they're the ones that zeroed it out. On the Senate side, is there a different story?
Completely. So our advocacy our efforts in general have been on the Senate because we know that with the current makeup of the House, unfortunately, the Freedom Caucus, they're calling the shots over there. And those appropriation bills are being stalled. I mean, I think they just couldn't even get the CJS bill out. And so we think the better approach is, yes, we were successful in beating back HOPWA, the HOPWA amendment, which would have eliminated HOPWA funding, the housing program for people with HIV/AIDS. We were successful in beating back some of these cuts. But I think our efforts have to be fine-tuned in the Senate, Maya, because at the end of the day, the House, we know, or not, if we can't beat back these amendments, we have to change course and go to the Senate, a much more friendlier territory, by the way. So we'll go to the Senate, and obviously, it would be hard pressed for President Biden, even if it got through the Senate, for him to sign such a bill that eliminated his program and his funding requests. So we are in a good position in the Senate. The House changes by the day.
Yeah. So, Guillermo, Dr. Fanfare mentioned racism, sexism, homophobia. She mentioned all these structural discriminations and how they are at play in shaping the experience and the nature of the response. First of all, do you agree that is, what's animating some of these, attacks on funding for HIV/AIDS?
Definitely, and I appreciate, all my fellow speakers here, because I believe this in particular is one of the most painful and difficult challenges. The stigma, and I'm talking about homophobia, transphobia, now xenophobia also, the fear for new immigrants, that is also another barrier. And I always told people, I say, I think from a public health perspective, we cannot walk away from those social issues, and especially stigma associated with some populations and some communities that will be a major barrier. And when you go deeper in the South, I was mentioned that, it's most of the HIV infections and an increase in the last few years of sexually transmitted infections are in the South. And it's when we have the biggest issues to have access healthcare. I think that's a critical part. And all these stigmas will be a major barrier. Now, from my perspective, more personal in terms of Hispanic, Latinx, or Latinos, Latinas, it go deeper, because we need to deliver that message both in English and Spanish and some dialects as well. You deal, for example, with Garífonas from Honduras and the Miami, but especially New York. They speak their own language. Mixtecos also speak their own language. You go to New York and in the subway, you will hear speaking. People say, what they speaking? And they say, I think it's Garífona. And I told people, I say, we need to understand those realities, and when you bring the issue of the stigmas that Dr. Fanfare was mentioning, it makes it a little bit more complicated. But also I wanna come back that the best thing that we can do is obviously challenge and generate political will, that these days is very complicated, but also it's about leadership. Public health will not be able to be in many budgets and agendas if each of us and all of us do not make accountable and challenge our elected officials. And I think Joe did a great job to give us an update of the landscape. But I really want to remind all of us that the theme that we use, and we putting together a big health policy summit to address a federal issues from Hispanic, Latinx perspective, and made here in D.C., that we want to bring also the issue of have clarity about bringing and rescuing what was crafted in 1998, the Minority AIDS Initiative, and then break it down to ensure that communities led by Black folks, by Latino, Hispanics, Asians, or Native are rescued in order to be a key partner and to be in the table shaping agenda and shaping priorities. Thank you.
And in fact, is that not an evidence-based strategy? Dr. Sharfstein and Dr. Fanfare, in the public health world, there are all these fancy terms. And one fancy term is called concordance, which basically means match. The research shows that culturally appropriate interventions matter for communities that are underrepresented and historically marginalized. And so, the whole notion of, if you have a doctor that is of the same racial or ethnic or linguistic comparability with the patient that they're seeing, then that patient is more likely to have effective outcomes. And the same thing, the evidence suggests that the same thing holds true for community-based organizations, that if you have community-based organizations that are led by, the population groups that's most affected, and they're serving and working with those communities, then the outcomes are going to be more effective. That is evidence-based. Is that not correct, Dr. Josh Sharfstein?
I would fully agree with you, Dr. Rocky Moore Cummings.
Smart.
So it's not just a matter of, we're not talking about, they're just complaining that they want to get money. We're talking about evidence-based strategies, scientifically shown evidence-based strategies.
Well, that's absolutely true, and you're absolutely right that there is a major underrepresentation problem in medicine and in other healing professions, and that has consequences for HIV and many other diseases, and people being able to get care and feel comfortable in care. And more broadly, racism has shaped the healthcare system in the United States and shapes access to healthcare in the United States. And so, it's like trudging up a mountain when you're trying to make progress on an issue when the mountain is all the obstacles that have been thrown in the path from decade upon decade of discrimination and bias. And that's why it's important to recognize you're climbing a mountain. It is important to see the mountain, and it is important to be thinking about how do we cut through it? How do we develop a strategy for engaging with the healthcare system, getting more providers who represent communities and are working with them, and getting more programs and pathways that actually can bring care to people where they are in ways that don't require them to, basically do the impossible in order to get the treatment they need.
So, Dr. Fanfare, I thought that I heard that you all were funding strategies that seek to do that. In light of the concerns and the considerations about, affirmative action laws and what that might mean for funding groups that are led by communities of color, how is the CDC interpreting, how to approach leveraging evidence-based strategies that rely on racial and ethnic and linguistic concordance in order to have effective outcomes?
This is on. Thank you, Maya. And I also just wanted to go back to your last comment and piggyback off of Josh's response. In addition to my job at CDC, I also serve as a medical provider for people living with HIV. And only 2% of physicians in this country are Black women, 5% of physicians are Black. And so there's so many people, you can see that incongruence with people living with HIV. And so it's so important and so inspiring being here, seeing so many wonderful faces of the young people being here, because as Paul said, you are the next generation of leaders. And so it's beautiful to see so many faces from all over the world here and inspired to do this work. I think the way that us at CDC are interpreting it is that it has to be community-based organizations. And so we have over 96 community-based organizations, and then 36 that directly serve same gender-loving men and people of trans experience who are of color, Black and Hispanic Latino. That's the way that we direct the funds, and then internally we are doing investigations to see who leads these community-based organizations. And we have some really promising data that we've seen from those internal investigations, but we definitely at CDC really do support the initial intent. But what we can do, we cannot use race as a way to direct the funds, so it is really after the funds have been awarded to the community-based organizations that do serve the communities, doing the internal to ensure that hopefully it is led by, and we welcome any of the work that Joe's doing on the Hill and that you're supporting as well, to be able to return it to its initial intent.
So why can't you use race? Just to be clear?
Because of the wording that's in the statute, now we can't use. Yeah.
All right, so, I want to pivot to the social determinants of health. We have, a situation where the burden of this disease is now actually being disproportionately borne on communities of color, even though we're 30%, African Americans and Latinos are just 30% of the U.S. population. They were 67% of new infections in 2019. Did you hear me? 67% of new infections in 2019, only 30% of the population. There are, I think, likely a variety of factors that are driving this. And I'd just like to hear, and by the way, those disparities have been apparent, by the way, since almost the very beginning of the disease. And the CDC figures show that in the late 1980s, about circa 1987, that the incidence of HIV, AIDS in African Americans surpassed that of white Americans. That was back in 1987. So I'd just like to hear, yes, Dr. Sharfstein.
Sure. Well, first of all, I think that percentage has gotten higher over time since 2019. But second, your point makes me think of a faculty member we have at the School of Public Health, Dr. Tira Willie, and she works particularly on HIV risk among Black women in the South. So a very, very population that we're really talking about here. And she focuses her work on the risk of intimate partner violence and the interplay with housing access, safety, and HIV risk. And what she finds is that you just can't think about HIV by itself when it relates to the relationships people are in, the fears people have for their safety, and their ability to be safe, literally, in housing. And that is one of many examples of how social factors and social, determinants, as it's called, are absolutely essential to really understanding, first of all, the enormous disparities, and then creating a vision for how you can make progress. People have to feel safe, they need options, they need access, and they need support in different ways. And there are consequences, too, for the healthcare system. There should be healthcare in programs for people with intimate partner violence, experiencing intimate partner violence, because PrEP, for example, could be very useful there, but oftentimes there aren't. The services are siloed. There should be services for intimate partner violence and all the HIV care. This is, one of the main points that she makes. And I think of her, and I think of this particular very tangible issue as an example of what you're talking about.
I want Dr. Fanfare to pick up, but I just want folks to get ready for your questions. We would like to take questions from the audience, and I believe that there are volunteers who will be wandering around with microphones. So raise your hand, volunteers. Those with microphones. We've got one over here, and where's the other? All right, back, okay, over here. So get ready with your questions. Raise your hand, and then they will come to you. Okay, Dr. Fanfare.
Yeah, I would just add that so many of the systemic issues that we see are leading to these disparities that we're seeing in HIV. So one, it would be access to safe and affordable housing. And one thing I'm really happy to see this past year is the coordination between quote unquote non-traditional partners at the table speaking about the intersection of housing and sexual health, because that's really important. Coming from Baltimore, as Josh said, I had so many patients who I had the honor of serving who were in and out of incarceration, right, because of the mass incarceration that impacts our Black and brown communities, the over-policing of our Black and brown communities. So I would have the opportunity to support them in achieving viral suppression, and then when they're in and out, now they're not virally suppressed anymore. So the impact of things like housing, mass incarceration, intimate partner violence, all of those things, it's much bigger than the medical model in HIV, but it impacts the disparities that we're seeing.
Do you want to add anything to that?
Yes, thank you, Maya. I really want to remind and challenge all of us, has been a sustained increase in impact in Black and Latino and Asians and Native Americans, but especially Black and Latinos and Latinas. And I think that issue has to be a huge red flag for all of us. And I really respect and admire anybody in public level working for a city, county, state, and definitely at the federal level. Because I know, and many of us know, how hard it is to work for a government entity. But I want to remind us that we need to put energy at the federal level, but don't forget our states and territories, because they shape and decide and put together the guidelines how healthcare is delivered in the 50 states and in the territories. And the other piece that I want to remind all of us also is that all those social determinants of health, and I definitely agree we cannot put HIV alone, especially when we have a large population living with HIV over 50. And we know, I'm 60, look good, but 60, that's the reality. And comorbidities are another challenge. And I told people, I say, a nation must be judged based on your budget priorities. And I think it's an issue about our conscience as a nation that we cannot leave anybody behind when we must do something dealing with those illnesses that are 100% preventable. And finally, I want to also remind myself and all of us that we need to also check our own internal biases, our own racism, our internal homophobia, transphobia, how we engage and how we bring and connect with people with respect and dignity is crucial. And I think the opening remarks I love that point because it really is about ensure that people that are dealing with an issue are in the table. If we're not in the table, we're part of the menu, and somebody will be choosing for us. Thank you.
Yeah. So being at the table is part of the political determinants of health. Do we have a question from the audience? Yes. Sir.
Hello, my name is Ludlow McKay. I'm a former commission officer. I worked at NIH and at HRSA and HIV/AIDS Bureau. And I see Captain Fanfare working with CDC, and I don't see any representation for HIV/AIDS Bureau. And one of the things that I always found was that there was no coordination between agencies, i.e. Ryan White Care Act, because I was there when, back in the, I guess, late 90s, early 2000s, when Maxine Waters became involved. And I came back, I went to a CBC meeting and raised the issue of how minority communities were impacted. And I went because I knew about the CBC. No one else from the Bureau went, and I came back and warned them. And we had to have put out a proposal to measure the impact of Ryan White Care Act in minority communities. So that was the time that you were working with them, Dr. Rocky Moore Cummings. And
what was the outcome of that? Was it a report?
There was some report.
Okay.
What the outcome of the report was, I don't know. I don't recall. That was
so we didn't know each other, but you were in the same rooms I was in back in 1998.
yeah,
it sounds like
we knew each other from another connection.
Yeah,
Your
absolutely.
husband and I were classmates. Okay.
You're the second. Were you a city grad?
No, from Howard.
At Howard University. Okay, very good.
We've talked.
Well, thank you so much. Did you have a question for the panelists?
So my question is how come there's no seeming coordination with HRSA, HIV/AIDS Bureau, and CDC in terms of what it is that you're doing? And that's my observation.
Oh, today.
Today.
So, yeah.
And
So
sometimes
we could have had a whole panel with the government officials by themselves, but we didn't have that kind of time. I do think that, yeah, go ahead.
For the panel, and when I speak, I definitely like to speak for CDC. I can't speak for other agencies, but I would love to acknowledge the strong partnership that we do have with HRSA. Joe spoke a little bit about the Ending the HIV initiative, Ending the HIV Epidemic Initiative, and HRSA and CDC are really the two implementing partners. And so we work really strongly in partnership for EHE, but not just for EHE, also for community engagement. We just finished joint community engagement sessions with HRSA, with CDC, where we went around all of the regions and the HHS regions to be able to hear directly about the community. And we hear very strongly about, just as you're saying, the partnership that needs to be there. How can we support braiding funding to make sure that the communication is going on between the two agencies? So that connection has developed and is growing and is there, and they are great partners to CDC.
He brings up a point about the coordination. And so the question becomes, I mean, with housing, with, SAMHSA, with, all of these agencies that have a piece of these monies, how do we actually reinforce coordination in ways that actually work on the ground for those who are who are at risk or living with HIV? Did you want to jump in, Dr. Sharfstein?
I think that's a great question for HIV, and it's not unique to HIV, because there are many issues where there are multiple agencies working on the particular challenge. And we saw some of the consequences of this during the pandemic, when there was different things that happened. And the Commonwealth Fund had a national commission to look at HHS and the challenging question of how HHS can be better organized to ensure better coordination, so that, just like you said, Maya, that first of all, the individuals, the citizens, the residents, but also the local governments, that they're seeing coherence. They're not just getting hit from multiple angles. That is a common challenge. And this commission actually recommended a new Undersecretary for Health with the mission of organizing across agencies to get that kind of support and coherence for public health issues. I hesitate to bring up such a big topic. It's obviously not on the agenda for this week in the Republican Congress House, but I do think that it is, something that, HIV, it's part of the mountain that HIV has to climb sometimes when that falters, although I do think HIV is probably a model more than other issues for getting that coordination to happen.
Very good. There are 3 questions right here, and they're going to be our last 4 questions.
Good morning, everyone. My name is Tiffany Hartman Stroud. I've been living with HIV for about 30 years. I'm one of NMAC's 50-plus scholars. I think that if we're talking about HIV, we do have to address people who are aging with HIV. I did work under the Minority AIDS Initiative for about 10 years, and we were linking people to care and people who are lost to care. And we ended up losing the funding after about 10 years. And a lot of the people that were lost to care, we lost them. And I'm not saying it's anyone's fault, but I always say the cure is in the room. And now we're working with different. Back then, people were getting PCP. They were dying. We would visit them in the hospital, and we were trying to fight for them to live. Now we have the medications, and we can't get them out into the community. So I was just wondering, my question is, if the CDC or HRSA has someone that can come to us as versus us coming to you all to help us with like grant writing and things that we can do, because I do have my own organization, but I also have to work to live. I'm a school teacher. So my husband just got a kidney transplant last year at Christmas through the HOPE program. So there's a lot of comorbidities that we're dealing with. And we're on the ground. We know the people. If you guys show up, they would be afraid because they're scared of government officials. So we know what to do. We just don't have the funding to do it. So I was just wondering if there's any way that we could get like liaisons to come to us, because I know a little bit about grant writing, but I don't know a lot. So a lot of the funds that we get from either pharmaceutical companies or grants that are like, they're like they're not government grants. So that was my question, and I just wanted to commend you all for being here.
Thank you so much for your question and for your comment, and it's also great seeing you again. I saw you and your husband share your testimony at USCHA at a panel that we had on HIV and aging. I'll speak for CDC specifically. We do have organizations that we fund for capacity building, and we hear so often when we go out into the community that smaller community-based organizations need that support for grant writing. So that is definitely something that I will take back to the team, the organizations that we fund for capacity building, and how, as we think of new notice of funding opportunities, that can be integrated to help support with grant writing that's needed.
And Maya, I'll just add, the reauthorization of the Older Americans Act is coming up next year. And NMAC is putting together a panel. In fact, we just sent out an invitation yesterday, or maybe it was Tuesday, to get together groups to talk about what are our asks for the reauthorization of the OAA, because the aging community is now the majority of Americans living with HIV. So it's very much on the minds of advocates. We know that. It's just now honing in and balancing, right? Balancing the current Congress, what we think we can get, and then honing in on a specific ask to address not only the grants, but the care for seniors and older Americans living with HIV.
Very good. Okay, next question. Who's got the mic? Hi.
Hi, Maya.
Good to see you.
You too. Thank you. Thank you so much for this. So my name is Fatma Tabari. I have a question. So what I've heard is the disparities that are in almost every sector of our nation. That is so great and the history of it is that how do we find equity in providing for those organizations and those groups that are being led by Black people, since they are so, since there's so many more of them being impacted but not receiving the proper services or are disappearing? How do we do that without, I don't know, I guess violating policy? Or how do we step back and say policy should be for equity to get everyone to where we are all supposed to be? And then we can talk about not looking at race and whatnot.
So if nobody wants to touch that, I'll take it. Do you want to take? You want to take it?
It's a very complex question. I will say that. Health equity in the terms of, and I understand the complexity of not identifying race or not overtly, I guess, identifying race when we deal with federal dollars. That was the whole intent of the MAI, right? And that, I think, is why we are looking. Well, I believe it is one of the driving forces why we're here to keep those fundings, to keep that funding in place. But more importantly, I think what the recommendation is just have an understanding of the politics of it right now in today's day and age, and knowing when to pull back and just try to, in other words, a win sometimes is keeping the status quo, right? And until the political climate changes, and perhaps even the court changes, I think then you can really drive into the racial factors of federal funding. But I don't know if now is the time to do that.
Yeah, I just want to add, thank you for that question and for the previous questions. I will only say that we need to work hard to elect individuals that understand that the path for equity is that. The U.S. has been changing. Look, since 1990 census data, all the way to the last one in 2020. And I think it's a challenge that we want elected at the federal level to understand that in diversity, beauty is a strength, but also it's a challenge to create will to shape policies, and especially public health policies that will address the realities that we face on the ground. Thank you for your question.
And I just want to say, and we actually have to wrap up because the next conversation is about this issue. How do you actually get to equity given the current climate? How do you do equity in the face of anti-affirmative action laws and sentiment? And I know that Jeff Crowley is going to talk about, compelling governmental interests, narrowly tailored solutions. And so we're going to get to that in the next conversation. So let's give a round of applause for this excellent panel. Oh.
Yep. I would like to say just one thing, Maya. When you mentioned me in the same breath as your husband, I probably should have said something right away, but I always get a little overwhelmed when that any mention of me with Congressman Cummings comes up. But I just wanted to say how much you would have appreciated this discussion.
In fact, you all should know that actually he was the first member of Congress to actually grant me an interview for my dissertation back in 1998. And that is how we met, through this initiative. So, yeah. So again, a round of applause for our audience, and then we're going to go to the next panel. Thank you so much.
We're moving right to the our next session. So it's now my honor and delight to welcome to the stage and introduce to you our fireside chat participants. As I call and introduce each one, I'll ask you to come to the stage. The first person is our CNN commentator, Jamal Simmons. He will serve as the host for today's chat. A longtime communications professional and veteran campaign operative with stints working with Clinton, Gore, and Obama, Jamal most recently served as Deputy Assistant to President Joe Biden and a Communications Director to Vice President Kamala Harris. He also has worked as political contributor for CBS News and NPR and has hosted digital interviews for HEO TV. For almost a decade, Simmons has worked as principal at the Rabin Group, where he advised corporate, political, and foundation leaders. Welcome, Commentator Jamal Simmons. And joining Jamal on stage are our fireside chat guests, including Lori Rubiner, who's a senior government relations counsel at Kelly Dry, with more than a quarter of a century working in and around Capitol Hill. Lori has served as chief of staff to Senator Richard Blumenthal, as legislative director for Senator Hillary Rodham Clinton from 2005 to 2008, and as a legislative assistant to the late Senator John Chafee. More recently, Lori served as special counsel to the Senate Judiciary Committee for the nomination of Brett Kavanaugh to the Supreme Court. Welcome, Lori Rubiner. Our next fireside chat guest is Alfonso David, who is a civil rights attorney, LGBTQ plus activist, and the current president and CEO of Global Black Economic Forum. This is an organization working to serve and advocate on behalf of the economic needs of the Black community. Prior to joining the Global Black Economic Forum, Alfonso was the president of the Human Rights Campaign, which is a nonprofit organization that strives to end discrimination against LGBTQ plus people and realize a world that achieves fundamental fairness and equity and equality for all. In 2015, David was appointed by the governor, Andrew Cuomo, to serve as the counsel to the governor. In this role, he functioned as the governor's chief counsel and principal legal advisor and oversaw all significant legal and policy deliberations affecting New York State. And final, but not least, fireside chat guest is Professor Jeffrey S. Crawley. He's a distinguished scholar and program director of infectious disease initiatives at Georgetown University School of Law O'Neill Institute of National and Global Health Law, a widely recognized expert on HIV, AIDS, and disability policy. Crawley has served as the director of the White House Office of National AIDS Policy and senior advisor on disability policy for President Barack Obama. In this capacity, he led the development of our country's first domestic national HIV/AIDS strategy for the United States. In September of 2019, he was appointed to the National Academy of Science, Engineering, and Medicine Committee on the Prevention and Control of Sexually Transmitted Infections in the United States. I'll now turn it over to Jamal.
Thank you, thank you. This is going to work. Can you hear me? There we go. All right. So thank you all for being here, and I want to thank Maya and the Center for Health Disparities for having me and having our panel here. Just as a way to open, in the late we've been talking about on this World AIDS Day, we've been talking about some of the numbers and how this disease has moved through communities across the country. In the late 1980s, the city of Detroit, which is where I'm from, decided that it was going to start giving HIV education to premarital couples. They saw that as a way to get real information into the hands of everyday citizens and people who were trusted parts of communities. So they were a captive population. In order to get a marriage license, you had to go through an HIV training course. The summer after my sophomore year, I was 18, 19 years old, I was hired to be an educator for these premarital couples who were all in their, 20s, 30s, sometimes 40s, who were about to get married. And so very often I get asked, how did you get comfortable being on television or, having these arguments with people who are, sometimes when I first started doing this, a lot older than you or a lot more experienced. And the first thing I think of, other than my raucous family table that I grew up in, is if you can do a condom demonstration on your two fingers in front of 30-year-olds when you're 19, you can kind of have a conversation with anybody about anything. And so that's how I came to this work. And so it's been a part of my life, and family members who've also been affected by this virus has been a part of my life since most of my life. So I want to start with you, Jeff, kind of on that point, because I think it would be helpful for us. Maya did some of this in her last panel, but it'd be helpful for us to get kind of a state of play. Where are we today on World Health Day and World AIDS Day in terms of the virus and disease and how it is affecting different communities disproportionately?
Great. So I think we still have major challenges, but we also need to recognize the huge success we had. In the 1980s, there was a point where we had 130, 140,000 new HIV infections a year. Now we're in the low 30,000s per year. That's too many, but it's major progress. We've heard that the share of the epidemic comprised of people of color is growing. That's deeply problematic, but we're also making progress across all racial ethnic groups. There's a question about the Ryan White program, and we today are releasing a brief on Black women and HIV. And this program does a remarkable job. It hasn't eliminated disparities, but viral suppression among all people in the Ryan White program, I think, is like 89.7%. Viral suppression for Black women is 89%. For cisgender Black women, it's 86% for Black transgender people. Those disparities matter, and we need to fight those, but it's not, when we heard earlier about PrEP uptake, it was 13% to 94%. So I think we need to recognize the progress we're making and recognize that means that policy and intent really can make a difference, and we need to focus on that.
So that brings me to the kind of where I started and where Maya's panel left off. What we saw with the Minority AIDS Initiative was kind of a broadening of the scope to not just target people of color, minorities, African Americans, Latinos, Latinas. We've seen this in other areas, and I'm going to bring you in here, Alfonso. We've seen this in other areas where we've had to broaden the scope of programs in order to comply with law. But how is it that you achieve different outcomes without doing things differently for people who are being impacted? I want you to solve this for us.
I think we face this problem here in the United States, not only as it relates to health policy or HIV, but I think generally with respect to all policy. I think so much of our policy is driven by fear, as opposed to being driven by facts. And if we were to start reimagining policy development through the lens of facts, then all of the scary arguments that we hear whittle away. And if we focus on the facts, we realize that 1 out of 2 Black gay men, bisexual men, will get HIV in their lifetime. 1 out of 2. 1 out of 4 Latino men will get HIV in their lifetime today. So if we're focusing on the facts and imagining how those facts should inform our policy, then we actually create solutions. But instead, the conversations we often have is you can't really talk about race. You can't really talk about ethnicity. It ignores the facts. So I'm often thinking about policy development through the lens of facts, as opposed to through the lens of fear, which is unfortunately what I think drives so much of the work that we see in policy spaces.
So, Laura, you do policy for a living, right? You have done it for a long time, particularly from the Senate side. When these questions arrive in front of legislators, and how do they try to find a way to attack the problems they see exist, but still comply with whatever the thinking is around not being able to really target the problem directly? trade you and I'll fix this one.
Thank you so much. I mean, I think there are a certain number of politicians and legislators, and I was really fortunate to work for 3 of them, who still believe in facts and are driven by facts. And they try very, very hard to adhere to fact-driven policy. But unfortunately, as David alluded to, there are too many now who are driven by other factors. And I do want to just pivot a little bit to another factor that is really sort of hanging over all of this, and that is the courts. Because I sat here and listened to the previous panel, which gave me so much hope and made me not want to leave this room because it was so fact-driven and made me feel so good about sort of the future of public health. But then I remembered what I do for a living, which is very steeped in what the courts are doing, which is really trying to make it much more difficult for what the public health community does in trying to make more equitable health care available for more people in lots of different realms. And that is something that I think we don't understand necessarily what the intersection between the two is. And that is that there is a very well-coordinated, well-funded, organized threat by a group of right-wing conservative groups that are trying to make it harder for us to do the kinds of things that we want to do in the public health space. And nowhere is that more evident right now than in the HIV space and in the transgender space and in the LGBTQ space. I spent a long time in the reproductive rights movement. We saw it in our movement. We knew it was coming to you, and now we have it.
Okay, so I'm going to follow up on this because you were in the Judiciary Committee during the Kavanaugh nomination. What does that look like in real time when you are trying to decide who's going to sit on the highest court? Who is weighing in? How is that, again, real time, what does that look like?
Not good. So when I was hired, we had a vacancy on the court, and they brought me in to manage that process for the Democrats. You know, we hire a whole group of, we hire a separate group, separate from the committee staff, to manage a Supreme Court nomination. We didn't know who the nominee would be. There were a list of people. Kavanaugh was obviously on that list. And then it became him, and then it turned into the circus that it turned into. You hire a whole group of people. There's all kinds of people weighing in, but it was the first time in my experience, and I just want to back up. I worked in the Senate for 23 years, and I started on the Republican side with a wonderful person named John Chafee. I spent a lot of that time in John Chafee's office learning about HIV/AIDS from Jeff Crowley, so in the 90s. So he taught me everything I know about HIV/AIDS. John Chafee was a wonderful advocate for people in the HIV/AIDS community. So that aside, I moved from the Republican side. When John Chafee died, I moved over to the Democratic side because the Republican side was no longer a rational group of people, and I went to work for Hillary Clinton. And then ultimately as Richard Blumenthal's chief of staff. So I've seen a lot of different sides in the Senate. I have never seen what I saw during the Kavanaugh nomination in the sense that the way that nomination was run, and I won't speak out of school because I can't, but most of the rules that I understood to be what the Judiciary Committee abided by were not followed. And that was mostly by the Trump administration and the way that they orchestrated it, but it was also by the Republican side of the Judiciary Committee. And I'll just leave it at that and just say that I was shocked and dismayed, and also because I am so old and had been around for so long, many of the same people that I worked with on the Judiciary Committee I had known back when I worked for John Chafee, and I was shocked at their behavior.
So I don't want to get you in trouble with speaking out of school too much, and then we're going to move on. But I do want to get a little sense, is it staffers? Is it outside advertising? Is it people who are showing up to testify? Is it all the above? Like, what does it look like for somebody who's trying to understand how the legislators feel the pressure of this coordinated effort that you're talking about?
It's such a well-oiled machine that they have, and they instill such a discipline on their members, on their staff, on their outside groups, and they work in such a coordinated fashion, from the Federalist Society to their members to their, it's such a well-oiled machine, and we are so not a well-oiled machine. I think that's part of the problem.
Well, somebody's on our panel who is trying to oil up a machine. So I want to, Alphonse, you in September started the Council for Economic Opportunity and Social Justice. Tell us about that, what your objective is of that confederation of 13 groups.
So thank you for that. We recently announced the Council for Economic Opportunity and Social Justice. And the reason why is because we think we need to coordinate in a much more substantive and strategic way. We need to coordinate how we're responding to the attacks that we're seeing against marginalized communities. And when I say marginalized communities, I'm talking about Black and brown people. I'm talking about people living with HIV. I'm talking about women. And what we're seeing is an attack on all of these communities that are connected. And people think, oh, well, it's really just about Black people. It's only about Black entrepreneurs. Well, it's only about transgender people. Well, it's only about women. Well, no, it's all about going after marginalized communities and deconstructing the systems that exist to support those communities. And as you just heard, there's a very coordinated campaign. It is not just, affirmative action was not stricken in a day. It's been a 40-year campaign, maybe even longer, to strike down provisions in education policy that allowed universities and colleges to consider race as a factor in admissions. And now they're going after Black entrepreneurs. Now they're going after MWBE programs. Now they're going after women. Now they're going after LGBTQ communities, because the goal is to ultimately get us to a place in our past where laws against discrimination didn't exist, where the right to privacy didn't exist, where the right to bodily integrity didn't exist, where the potential for economic freedom didn't exist. That's the goal. And so we think it's important that we counter that attack, that we are proactive, that we're strategic in thinking about how do we prepare, not for what we're seeing now, but what we're going to see next year, and in 5 years, and in 10 years. Because this is not just about one election cycle, right? This is about a campaign to completely demoralize and deconstruct systems that support marginalized communities. So 13 organizations, from the NAACP to the National Action Network, from the Lawyers Committee on Civil Rights to the LGBTQ Task Force. And we're working collaboratively to really come up with strategic plans to counter what we're seeing, which is a coordinated right-wing attack on marginalized communities.
So Jeff, as you listen to this and you think about this, how do you contextualize your work in the healthcare space with this coordinated attack? Do you see these connections and similar tactics being used across attack vectors, let's say?
Yeah, I mean, it's interesting. Lori mentioned her work with Senator Chafee. The Medicaid program is the biggest healthcare program for people with HIV. And in the early 90s, there was a huge threat to that program, and we still have an entitlement to Medicaid because of her boss, the late Senator Chafee. At the time, there were people in the HIV community said, we've just got to fight our own battle. We've got to get a carve-out for people with HIV. The way we defended that program and maintained it is all the groups that benefit came together. And I think we need to think that the HIV community and attacks on the minorities initiative are part of this broader effort. we'll be the leaders on one piece, but we've got to support others. And I think that's a critical part of how we do this. The other thing is I think that we hear these attacks and we say, oh, don't poke the bear. We've got to tell our story and own it. You know, they will tell you a story that, oh, we're giving special things to all these favored groups. That's not what we're doing. We're trying to address inequities and make the country fairer, not favoring one group over another.
All right, so I'm gonna throw up lob up a ball and see who wants to hit it. We've got a new Speaker of the House, and it is being widely reported that he has spent a lot of time in his career with some people of the pretty far right. I think Maya this morning on Morning Joe, you called them ultra nationalist Christian, right? Did I get that right? But you know, so we're seeing people who seem to have a very different idea of the separation of church and state, the separation of their faith has always been a part of the American dialogue, but the inclusion of it in policy in a way that we haven't seen before. What's the impact of that on this fight that we're talking about?
I mean, I think from the founding of our country, we always saw the separation of church and state, and religious freedom was supposed to be a shield for us from the state imposing their religion upon us. It has completely flipped with people like Michael Johnson. Is that his name, Mike Johnson? Who has, I think I've blocked it out of my head, I think, where they've flipped the concept of religious freedom and weaponized it against the most marginalized. And so when you see things like the Braidwood case, that is the case where private employers are saying, it's against my religious beliefs to provide PrEP to my employees. Or, which started with Hobby Lobby, which was, where they said it's against my religious beliefs to provide contraception. We always knew they were going to come for other things. That's taking the concept of religious freedom and flipping it on its head and weaponizing it. And what's so particularly dangerous about that is not only that it's denying, we heard so much about all of these marginalized communities that are losing access to these important drugs. And the courts are going to make that so much more difficult by saying, in the health insurance context, we're not going to cover it because it's against our religious beliefs. Well, that could then be extended to, if the courts say that that's okay, that's in the private insurance context, but that could move to Medicare, that could move to Medicaid. And then what do we say about other kinds of things like vaccines? What if I decide it's against my religious beliefs to provide vaccines? So it's a very dangerous thing, but I think when you have somebody at the helm of the House of Representatives who espouses those beliefs, we have come very, very far from the kind of Republican I worked for, John Chafee, who was one of the senior ranking Republicans not that long ago.
If I can just say, in addition to the danger that exists in the legal context, there's also an additional danger from a very practical, optical context. The narrative that's been driven is that you cannot be a person of faith and LGBTQ. You cannot be a person of faith and Black. You cannot be a person in faith and pick the demographic group. Because the narrative that's been driven is you have to pick. And there's not possible to be a person of faith and honor your faith as well as want an equitable space and protect people who are marginalized. And that's an important narrative that we have to combat. Because if we ignore it, then the concept becomes, well, if you don't support this theory or this principle over here, which is what we call religious freedom, then that means you're not really a person of faith.
Last year when the Dobbs decision happened, I was at the White House, and one of the things that the vice president began saying, who really did set the tone for the government about how we were going to respond on the question of abortion rights, was that you did not have to give up your faith or long-term, long-held beliefs in order to believe the government shouldn't have a say over what women do with their bodies, right? And it was a very specific phrase that she used to talk to people of faith about the fact that however it is that you conceive this question, you don't want the government to be in the room with the woman and her doctor or her faith leader or her family or whoever else it is she chooses to include. You don't want a government official sitting there also. And we found that was something that resonated a lot. People wanted to hear that, people of faith who are wrestling with this question. Lori, I'm going to go back to you and then Jeff on this question about the speaker, because what we have seen over the course of certainly the last decade or so, are things that seem to be fairly marginal ideas or communities or beliefs steadily march toward what became the mainstream of American political thought, right? And so the idea of being a dominionist or however the Christian right is phrasing their belief about how they should engage in American civic discourse, 2 months ago, those were a bunch of people who were on the internet and we weren't really talking about them very much in the public sphere, and today they're second in line to the presidency. One of the people who affiliates with them, second in line to the presidency. So we're seeing that. Do you see this also happening in the Senate, where you guys worked? I mean, is this, we think of the House as being the place that's cacophonous and all these different ideas, but a lot of these folks end up running for the upper chamber too.
I mean, there are some, the Senate has become the House. There are a lot of people who I think John Chafee would not recognize in his party as Republicans. I mean, it's not, it is a very different place than it was when I started working there in 1985. It's just it is a completely different place. When I started working for John Chafee, he was a pro-choice Republican. I know you can barely even say those words together anymore.
Lincoln Chafee's dad, for
right,
people who may be
right, exactly.
So even Lincoln Chafee now might date us.
Yeah. Now, believe it or not, there were 10 pro-choice Republicans.
Yeah.
And we had a coalition. Now they weren't completely pro-choice on all things, but they also were in favor of funding for HIV, and Chafee led a lot of those efforts, and it was so far. Talk about things that were so far removed from, the reality. The idea that you would be anti-contraception was crazy. I mean, we knew that would never happen. I mean, they might be anti-choice, but they'd never be anti-contraception. Look where we are now. I mean, that is common. So yeah, it is not a place I recognize.
John.
So one thing I would like to remind us is we hold majority views. I think we often feel under siege, but like the speaker, he probably has terrible views about the LGBTQ community. But I think since he's become speaker, he said that marriage equality is settled law. He knows he can't get away with probably advancing what he truly believes because our views are popular. But I think we sometimes...
I was hard on this because didn't Justice Kavanaugh say the same thing about choice, about Roe, that it was settled law?
Right.
Right. In his confirmation hearing under oath.
But they say that because our view is popular,
Right.
is the point I'm trying to make. And we've got to own that. We're not trying to protect a minority view here. The American people, I believe, are proud of their commitments to HIV because we sustained it for decades. They're proud of the fact that we're saving 25 million lives of people with HIV around the world. So the idea that we're going to attack this, we shouldn't respond defensively. We should own the fact that we're defending a popular view.
So talking about flipping something that's on its head, a law on its head, Alphonse, I know that you have been working with the Fearless Fund, which was trying to put money in $20,000 grants into the hands of Black women entrepreneurs, Black women business owners, and they faced this anti-woke, anti-legitimate attack. And so they're flipping the civil rights laws on their head in these attacks, right?
Oh, absolutely. And for folks who don't know, the Fearless Fund is a venture capital firm. and they have a foundation where they provide grants to people of color, women, primarily Black women, who are looking to scale their businesses. Now, why is this needed? Well, it's needed because of the $288 billion with a B, that's allocated through the venture capital space every year, only 0.003% or so goes to Black women. So they created this company to try to funnel in resources to Black women, and they do that through a grant process. And they've been doing this for about 4 years, successfully. And they were sued. And ostensibly, the argument is providing grants to Black women violates federal law. Now, you ask, which law? There was a law that was passed in 1866, right after the Civil War, to allow Black people to enter into contracts. Because remember, before, a Black person couldn't enter into a contract. Black person was considered property. A Black person couldn't get an education, right? So these laws were modified after the Civil War, and this specific law, we call it 1981, was passed in order to allow Black people to enter into contracts. Now that law is being turned on its head. And what they're saying is, you're providing grants, it's not a contract, but they're saying grants to Black people and thereby violating a federal statute that's been on the books for decades. The statute that was intended to specifically help Black people to advance themselves and to gain economic freedom. So the point I was making earlier, I want to highlight again, is that that attack is not limited to Black women. It applies to women. It applies to people living with HIV. It applies to all marginalized communities. And if we open up the vortex and we look at this case, and we look at all the other cases, we can look at the Roe, the striking down of Roe. It's all a coordinated attack to really strip away at fundamental protections that we have. So it's a very disturbing case, and it's not the only one. They've filed a number of cases. They sued 2 law firms. They've filed a case against Hello Alice. And when I say they, these organizations that are propping up to bring federal litigation, arguing that these statutes that have existed to protect marginalized communities should no longer exist.
So I think one of the law firm cases, is that the Perkins Coie was
Yeah.
one of those? So they go after Perkins Coie, which is a fellowship program for people of, I think, targeting historically underrepresented communities in the law, where you see, I don't know, 2.5% of law firm partners, major firms, are African American, right? So again, we get to the question of you can't actually get a different outcome if you don't do things differently. So I'd like to ask the panel, what are they really up to here? I mean, there's a lot of fish in the water, but what are we up to here from the other side? What's the America they're trying to achieve?
What's the America the other side is trying to achieve? Well, I think they feel that they've lost a lot of ground and they're trying to get it back. And one way to try to get it back is to privilege their community over others. And they're using the law to do that. I mean, that's sort of the way I see it, right? So. And that goes back to, I think they have their own fears, right? Like they see a world that doesn't look like the world that they're used to, where they're no longer in a position of power. And one way to get that power back is to use the law to privilege themselves over others. And I think it's incumbent upon us, and I'm very excited to hear about the program you're working on to find ways to push back. And
I'll give you one number just on the point you're making. In 1996, 85% of American voters were white. In 2020, that number was 69% of American voters were white. So what you're saying, I think in Virginia in 2012, when Barack Obama ran for president, something like 60% of white voters in the state of Virginia voted for Mitt Romney, and Barack Obama won the state of Virginia. So I imagine there are people who grew up in a different when things work differently, who are discomforted by these kind of outcomes. But what is so that's the world that they may be trying to hold on to and protect. What's the world that you all think this counter narrative, this counter effort that we're up to, where are we going? Are we just trying to get back to a status quo that existed before the Trump court took place, or are we trying to go someplace even further? I'll start with you, Alfonso.
Happy to start. I would say ultimately, and I'm speaking for myself here, but I think many others that I've spoken to would echo these comments. We're trying to get to a place where we achieve liberation. And if you sit with that word for a second, and you think about how we are so far from that concept in so many different aspects of our lives, that's ultimately where we want to get to. We want to get to a place where we don't have to deal with poverty in the way that we're dealing now, with disproportionately Black and brown people being confronted with poverty. We don't want a world where most of the new HIV infections are Black and brown people. We don't want a world where women have lost the right, at least under federal law, to control their own bodies. So it's not getting to the place where we were before Trump was elected. It's trying to imagine a world where we can actually achieve equity, where we actually have economic freedom, because we don't have that, and we didn't have that before. And we have to constantly think about the dream that we want, as opposed to getting back to the place that we had, because that place was only a stepping stone to get to a place where we can actually realize what I believe is the full promise of this country.
Yeah, I wanted to jump in just specifically in the HIV context. It was President Trump whose initiative was ending the HIV epidemic. That's an exciting idea, that we could end HIV as a public health threat in the United States. We can't do that if 75% of new diagnoses are people of color and we don't focus on people of color. But working in HIV, we always had to fight this idea that we're doing all these special things, giving people with HIV special things that nobody else gets. And even in the Minority AIDS Initiative. But let's think about this. If we know we need to focus where the need is greatest, in the Ryan White program, we have a special part of the program for women, infants, children, and youth, where we send funding to make sure there's capacity to provide services there. CDC programs, others, we use formulas. We distribute funding to states and jurisdictions based on where the need is. The Minority AIDS Initiative doesn't promise people of color a special benefit. It just invests to say we need to have the clinical capacity and other services capacity to serve these populations effectively. This is a way of ensuring that our public investments are having the impact we want. Like, why waste federal money, if it's sending it places it doesn't need? And so I think we need to keep telling a story about, it's an exciting vision of ending the HIV epidemic, and this program is how we get there for everybody.
Yeah, I think one thing I would add to that is, I think we want to think about things as, it's not a zero-sum game. And I think the way we think about public health doesn't have to be thinking about it as a zero-sum game. Just because there's one particularly impacted community, and if we use our resources to help that community, it doesn't mean that another community isn't going to get what they need. And I think as long as I think we need to get to a place where we stop thinking about resources as a zero-sum game, because that's their strategy, is to impose that kind of thinking on public programs. And that's what sort of backs us into a corner. And the other thing I would just say is that I think the biggest mistake we make as a progressive community is that we're always on the defense, and they have better language. So, I always think to that horrible term, back in the 90s when they used partial birth abortion, and they'd say, you're for partial birth abortion, and we had no idea where that was coming from, and we'd say, well, no, we're not for partial birth abortion. And then we kept repeating their language. And so we just have to stop doing that. We have to stop using their language, and we have to stop being against what the crazy things that they're for, and for what we are for. And to Jeff's point, sort of affirmatively stating that.
Okay, we'll take this moment to get questions from the audience. So if you have questions, how are we doing this? They go to the microphones here. Right. Or people, or someone moving around the auditorium with a microphone? Okay, so if you have a question, raise your hand. I'm going to take a counter while people are pulling their questions together and the microphones are getting to you. I'm going to take the counter position for a second. Is it possible that we're being lazy by using race? Is it possible that we are we're using race as a proxy that we really mean other things? We mean income or poverty, or we mean people who don't have access to healthcare facilities, or we mean some other set of indicators that we're using race as a stand-in for when perhaps we could use those other indicators. Jeff, you look like you're ready to hop in on this one.
I don't want to legitimize what you're saying, but I also think you're pointing to the solution. There's another way to get there. And one specific example is CDC has this measure called the Social Vulnerability Index. They look at census tracts and use factors like poverty and other things. It can get you to the same outcome. If we all agree that we should focus our resources where they're most needed, we don't need to use race, but I also don't want to say it's illegitimate to focus on race.
You know why I think that's not true? Are you a tennis fan?
Enough.
Okay, Serena Williams, she almost died in childbirth. And why? Because, and she has all the resources in the world. Nobody would say that woman doesn't speak her mind. And her doctors would not listen to her. And she literally almost died in childbirth. And that's why I think, it's not, yes, there are lots of socioeconomic factors. There's stratified environments, but there's also just the fact that the maternal mortality rate in this country is going way up, and who's it going way up for most? It's Black women. And why is part of that reason? Because their providers won't listen to them. And she's a perfect example of that. So no, I don't think so all the time.
What she said.
So you guys are saying racism is real?
100%.
Yes. All right, did we get a question from, there we are.
Thank you for having us, and thank you for the conversation. My name is Jamal Slocum, representing professor at George Washington University. A word that I heard this morning is the word we. And I think that when we, particularly in health equity, but when we begin to have the conversation about we in the context of the inequalities and understanding our national identity, the word we begins to dissolve very fast. And I mean that in context after 9/11, after an election, or after World War II, the Americans identify themselves as we. But when we start talking about the inequalities, the misdeeds, the sins, and the injustices of our country, it becomes, it's not my fault. I wasn't here when that happened. Why does it matter for me? So my question to you is, when do we appropriately use and correctly use the word we, and who should be listening and who should be speaking when we're having these conversations and advocating for the things and solutions for health equity?
You want me to start? Okay, happy to start. Look, I think the fundamental problem that we face is we haven't, as a community within this country, decided on what the solutions are. The past does inform the solutions, but often we're focused on the past as opposed to focusing on the solutions. So if you were to talk to someone who is not Black or brown, or someone who doesn't have HIV, or someone who's never met anyone with HIV, assume that's possible. And you talk about the challenges that we face in the HIV space. If they don't appreciate the solutions that we have to create in the HIV space, regardless of whether or not they have a role in what happened in 1980 when Reagan wouldn't say HIV for a while, then we're not going to get anywhere. But what I find is often we're talking about what communities did in the past that exacerbated what we are confronting today, as opposed to focusing on what is the solution, and do you agree that we need one? If we can get to that place where we as a community within the US and the global community can agree on what the solutions are, then there's a path for us to say we. But I agree with you, until we get there, we're having fractured conversations.
Anyone else? There you are.
Thank you all for holding this space. My name is Jeff Klein. I'm from the New York City Department of Health. And Jeff, you brought up the point that this is not a minority opinion, and I think that was demonstrated in places like Kansas and Ohio, where women and enough good men showed up to say, women should retain the right to control what happens to their own bodies. But how can that public opinion be leveraged to protect health equity and things like, the HIV epidemic, which now when you have at the federal level, cutting of funding, how can that at a local level, that public opinion be leveraged like it has been with a women's right to choose?
That's a good. I don't know that I have a good answer, but maybe a theme you've heard from me is I do think we have a positive story to tell, and we need to not be afraid to tell it. And so I think at the local level, we need to talk about why we make investments in HIV programs, why they strengthen all of our communities, how it does reflect American values, that helping everybody. I know that's a tough sell sometimes. But I'm not the person to give you the right language, but again, if we believe there's broad support for what we're doing, we need to not be afraid to engage in people and help them understand why what we're talking about is important.
Well, I'm going to remind Jeff of what he said earlier, which is that it helps to be with other people who are also marginalized communities. So one of the reasons that we had such success in protecting funding for HIV in the 90s is we kept the programs together. We didn't separate them out. And so I think that's also a really important thing to remember. I'm going to point something out that's going to make people uncomfortable, but I was vice president at Planned Parenthood during the ACA, and there were big tables of people who were fighting for healthcare access, but we weren't invited to that table, even though we were so central to the mission of the ACA and ultimately to the success of the ACA. And it took a lot for us, money and brawn, which I thank Cecile Richards for, to get a seat at that table. And ultimately, I think it showed that having us there was really important in getting passage of the bill. But I think it just goes to Jeff's point earlier that we need to stick together. So marginalized communities, people who are fighting for important rights need to work together. And that's one way that we can make sure that we continue to have rights to really important health care.
The final point I'll make, just to sort of echo what she just said, is I think often when we are confronting challenges within certain communities or when there's an issue that affects a certain community, we amplify it within that community. And we're not thinking about a broader ecosystem. The other side does a great job of taking their narrative and applying their narrative not only within their specific ecosystem, but much further beyond that. And for us, I think one of the challenges we face is there's an issue, it affects this community. There's an issue and it affects this community. Or there's a study or there's a report or there's data. And we're amplifying it only within certain silos. And that's, I think, one of the things we have to break down if we're going to overcome the challenges that we confront, and I seriously believe that we can. We just have to work in a much more coordinated way.
Questions?
Yeah. Wow, you just segued right. My question. So I'm Black, African, Muslim woman living in America. The intersectionality of my reality is not always spoken to when we have these conversations, or Lori, when we talk about how we get policy and how we promote it within the progressive world and the progressive grassroots. How do we do that in a way where we don't end up with what we have now, right? We say majority is our opinion, but you look at leadership, it doesn't reflect that. The people who make the decisions that impact us does not reflect the majority opinion, right? And so we have a difficulty in the Supreme Court. We have a difficulty on the Hill. Things like that are actually happening, and policies and decisions are being made that are negatively impacting us as a people whose majority opinion supposedly is a strong opinion? How do we message for each community, and how do we strongly stand against that which is being done to harm us on purpose and without any sort of qualm? How do we do that?
See, I was going to say we'd look to people like you, but I also say, like, when I talk to young people, they often act as though, like, us older people just need to get out of the way, and it's like power is not ceded; it's taken. So I think these people that feel like their identities aren't reflected, create that space or force your way into the room. But I also believe, like, say in the progressive community broadly, I think we aspire to be better than we are. So we need to learn how to do this and be better partners with others. And so I think it takes people that have the experience of feeling excluded to show the way in some ways.
And I'll just say that there's been an intentional breakdown in civics in this country. There's a reason why our education system is broken. There are many in this country that want it to remain broken so that people don't understand the role of government. And they don't understand the impact that government can have in their lives. So if someone were to have told some voters that electing Donald Trump would have radically changed the composition of the courts, changing the rights for women, changing the rights for other marginalized communities, they may not have fully appreciated that because we don't teach civics anymore. And so in addition to, I think, using our resources to be better informed, a better informed electorate, I also think we need to shift so people understand that we vote to exercise the right, not to necessarily vote for a person. Because I lived in Liberia, this is where I grew up, and we lived in a democracy for 10 years. And then on one fateful day, it shifted to a dictatorship. And we lost all rights. But I think in this country, for so many people, we don't have that threat, or we don't believe that threat exists. And so we don't appreciate as much as we should the importance of voting, just to vote. Not to vote for a person, but to exercise the right. And I think those are the two things that we have to strive to improve.
So I'm going to get to some more questions. On that point, a lot of times we talk about voting as if it is the answer to the problems that it is that we have in the community. So, here's a problem, go vote, right? But then people get in office and they don't necessarily move on the thing that we are voting for. So what's the step after that? That this effort is calling us to do? What is the where do the troops sign up for the fight?
Accountability. That's where it is. And there are many organizations that exist to hold elected officials accountable. And we need to support those organizations, that they're legal organizations, they're political organizations, and they don't have enough support to do the work that they need to do. There's some, and for some who may not be deeply steeped in this, there are 501c3 organizations, there are 501c4 organizations. Planned Parenthood is both. There are some organizations that can do both. A C3 cannot do political endorsements, a C4 can. And when you support those organizations that are able to hold those elected officials accountable on your behalf, we then have a louder microphone. And when we don't, we're speaking alone. So think about it. When you go to the ballot box, you're voting for a specific person, or maybe for a party, or for a specific position. And then you leave that ballot box, and on the federal level, 2 to 4 years before you can exercise that right again. So during that time frame, you need someone to monitor them. You need someone to oversee what they're doing. And that's the role of many of these advocacy organizations that we have to support in a much more sort of forceful way.
Can I just add something really mundane to that? Having worked for 3 members of the Senate, it's also, accountability is really important, and I was going to say that too. But the flip side of that is also remembering when you support someone and they do something that you like, remember to thank them. Because positive reinforcement is also really important. And sometimes members just don't hear when they do something good. They only hear when they're doing something bad. And it's important for them to know that they're appreciated and that what they've done is good so that they can keep doing good things.
As a parent of a 4- and 5-year-old, I agree that is a healthy way to encourage good behavior. Jeff, did I see you wanted to get in here?
No, I was also going to say we need some maturity about thinking about what our expectations are. You know, when I teach students, we talk about politics. I always say we'd use it as it's a dirty word. You know, when you vote, it doesn't mean did you get exactly everything you want. There's lots of interests, and politics is about balancing those interests. So did you get it enough, or did you see your elected officials working for you? But it can't be this binary choice of like they did everything I asked for or they did nothing. You know, we need some maturity about this. There's a lot of interests that we may not agree with, but they still have a right to an opinion or to advance their interests.
Okay, did I see more questions? I see a gentleman in the center.
Oh, I can. Thank you so much. I'm Jesse Milan, CEO at AIDS United, and thank you for this amazing panel, and Paul, congratulations for this entire forum. I'm wondering if, as we're thinking about the politics of race, whether our arsenal as advocates has missing something that the other side, the Republican side particularly, is used to addressing, but that we are afraid to address. Our social justice agenda is very clear, but theirs is also not only an anti-social justice agenda, it's a pro-fiscal responsibility agenda. And I'm wondering, are we missing in our arsenal the economic impact of what would happen should they cut the funding that we think is that we know is so important for saving our lives, but we're not really talking about the cost to the economy of should we in fact die. So are we missing that, or are we afraid in our social justice arena to not talk about the economic impact as well as the social justice impact?
Mr. Black Economic Forum. Yeah.
Okay, the hot seat. I don't think we're afraid. I think that the narrative is disjointed. So you have the Black Chamber of Commerce that makes these arguments. Ron Busby runs that organization. You have the Global Black Economic Forum, we advance those arguments. You have the Black Economic Alliance, they do that as well. I think, when we look back to Martin Luther King's speech on the March on Washington and on many of his other speeches, he was focused on economic and social justice. But what often gets the attention in the press is the social justice component. And we have to sort of meld those arguments to make sure that we understand you can't really get to liberation. You really can't get to freedom unless you have economic freedom. You can pass laws that says don't discriminate based on race, ethnicity, HIV status, but if you don't have the resources to actually get to economic freedom, you can't get to liberation. That was his narrative in the 1950s and the 1960s. But I think the focus that we often hear about, that we read about, is on the social justice component. And that's what we're looking to change, to make sure that we meld those two conversations and people understand the relationship between the two. And also, I think he was also saying earlier that there is an economic component to sort of the rise in HIV infections, specifically among Black and brown people, that conversation has to be amplified as well. It can't just simply be more Black and brown people are getting HIV. It needs to be, and as a result, this is the impact.
I'm going to give you a little bit of a behind the scenes of political fundraising that could be helpful in this. There are some groups that politicians go in front of, and the politician stands up and speaks or meets with people and will speak for 15, 20, 30 minutes, and then people will ask questions based on what the politician said. There are other groups where the politician shows up and the other people speak for 20, 30, 40 minutes. And then the politician is asked what he believes or she believes about what the agenda that is set out by the people who had the conversation. I would argue to you that the latter format is one that more directly gets the politician to understand what your agenda is and how it is you're expecting them to perform for your votes and your support. So keep that in mind the next time you have somebody at your home for a cheese Danish. Did I see any? Yes, over here.
Hi, Harold Phillips, Director of the White House Office of National AIDS Policy. I have a question that I would like the panel to kind of go back to a little bit. Between this panel and the previous panel, we are very clear that in the federal government, we can't use race as a factor in making the awards or the contracts. And Jamal, you went down a pathway that kind of gave a solution that perhaps we've been brainstorming about within government, about are there ways to think about using HIV surveillance data, social vulnerability index, income poverty data, housing status, to be able to achieve the same aims of the Minority AIDS Initiative, but without using race. But what I feel like I heard the panel say is that we need to use race, and those of us that are having this conversation within government are not ignoring the racial inequities or the fact that racism is a public health threat. We've been thinking about and talking about other ways to achieve the same aims, knowing that Congress right now is in a place where work is, what's the word? Happening slowly, not at a pace where we can end the HIV epidemic with that by 2030. So are there other methods and things that we could use at our disposal currently to achieve these aims? What I feel like I heard the panel say is no, that we need to really and truly hone in on race, which would then mean that we would be hamstrung until Congress works. Can the panel clarify for me that piece of it?
So I would like to respond, and Harold and I have been having this dialogue. I think there's less disagreement than it might seem. What I would say is it's legitimate to talk about race. That might not be the wisest thing to do in this environment. I've heard you and others say that it's not legal, according to the statute, to use race. I don't believe that's true as a matter of law. But I don't think we need to fight over that, because I think you and Jamal have spoken to the solution out of this, using these other metrics that will get to the same outcome.
I mean, you must be able to talk about race because there are lots of conversations about Black maternal health, and specifically thinking about the impact on Black women when it comes to maternal health. So the question is, I don't know how what exception it is that allows that to occur, but then not have it occur in these other environments.
So, conversation, there's acknowledgement, and there's the data, then what's the actual implementation? And I think that's where the overall challenge is, sorry.
What's the implementation is what he's saying.
What's the implementation?
So what I would suggest is data, data, data. If you pick 100 people who are confronting health disparities, most of them will be Black and brown. And when you speak to those people or solicit information from them, you can ask them about socioeconomic status. You can ask them about all of the other indicia that corresponds with the health disparities. And what you will find, because we know this to be true, is that there's a direct link between race and these other factors. So even if you can talk about race, but you can't apply it, and I agree that as a matter of law you could, but we don't have to debate that, even if you are reticent to apply race in the funding application, you could look at other indicia to actually advance the funding through those lenses.
Yes. Ms. Ruda.
I thought that I would hear this from Jeff, but I'm going to bring it up again. The Supreme Court has said that these affirmative action, race-specific, ethnicity-specific, programs and funding structures are not preferred and outlawed it outright in the case of higher education admissions, and has made other judgments with regards to minority contracting. But there's always been an out clause on unless there is a specific and compelling governmental interest and a narrowly tailored solution. And I would argue that in the case of the Minority AIDS Initiative, in the case of Black women's health disparities and other significant cases that rely on race in order to get to the solution, that there is a compelling governmental interest and that these are narrowly tailored solutions. What do you say to that?
So let me first acknowledge that I'm a non-lawyer next to two lawyers, so they can correct me. But so I think the Supreme Court precedent that defines this is the Adirondack decision that was given before the Minority AIDS Initiative was enacted. So the Congress was aware of this. They enacted the Minority AIDS Initiative. Adirondack said that the direct use of race is subject to strict scrutiny. So again, as you say, there's this test. It must further a compelling government interest, be narrowly tailored. They said you can't use race in so it's negative for one, plus for someone else. And that was came up in the context of university admissions, where there's like one slot. If you give it to a person of color, there's one less slot. With the Minority AIDS Initiative, we said that really doesn't apply because you're just funding, you're not giving anyone a benefit that someone else is losing out on. And the third is that there needs to be a logical endpoint. And again, we could argue with the decision around university admissions, but they said, well, when do you know when this goal has been achieved in university admissions? I would argue in the context of the Minority AIDS Initiative that fighting HIV is a numbers game. You look at epidemiological data. Have we met our goal for ending the HIV epidemic among people of color versus white people? And when that disparity has gone away, it's ended. But that's sort of like what as a non-lawyer thinking what the law says. I think the different argument, though, is the politics. Do we want to create a crisis if we have another way that we can get to the same outcome? And I think that's what Harold and others are suggesting, is maybe using some of these other factors, it will still get us organizations that are led by people of color, but it may not be specifically using race as the factor that gets us there.
Can we just make a clarifying point about the Supreme Court decision? Because this goes back to the importance of not adopting their narrative. There is a Supreme Court decision that was issued this past summer about affirmative action in education that applies to Title VI, funding that colleges and universities are receiving federal funding. Does not apply in any other context. The other side will argue the court has basically struck down affirmative action in every single segment of our lives. That is not true. It only applies to education policy. Doesn't apply to MWBE contracting. Doesn't apply to HIV funding. Doesn't apply to anything else. They will make that argument. Now, there's a separate issue about politics and whether or not we want to go down that road. But as a matter of law, the fair admissions case is only about education. It does not apply to anything else.
But there is a chilling impact, right? I was having dinner with someone recently who focuses on board diversity, corporate board diversity, and was telling me that they're finding boards willing to say, we'll pay the fine or the cost of not complying with a program or something we've set up, versus taking an action that could get us sued, and then we end up having a larger settlement that we have to make later for that. So it's chilling people's action to say, like, you know what? We'll just push back from the table and not engage in this.
That's true, and I think we face a different challenge there. So the education case that I just talked about only applies to education. But the flip side is we're not hearing about the positive cases. So think about NASDAQ. NASDAQ issued a policy that basically said, if you are a company that's trading on NASDAQ, you need to have diversity on your board. They were sued, and they won. The question is, how many of us know that? We know about the Supreme Court case that strikes down affirmative action in education, but we don't know about the NASDAQ case. And I think that is the narrative war that we're confronting, where our losses are amplified and our successes are diminished.
They want to chill us, right? So they want us to believe that the affirmative action case is going to apply to healthcare programs, and so that people will be afraid to apply race. But I mean, Jeff's organization did a great explanation of why the 3 prongs that are applied to the affirmative action case don't apply to this program. And I encourage everyone, they handed me a really nice one when I walked in, but I encourage everyone to read it and to repeat those arguments out in the public space so that they become the narrative rather than their narrative.
So, Lori, one way that we know that the coalition of forces who are arrayed against the good guys, let's say, who are arrayed against this agenda, has been focused specifically on getting people placed into the courts. Has the left, Democrats, whoever the progressive community, taken on the issue of getting people onto the court in a way that is more effective than it has been the last generation?
So I was part of a small group about 15 years ago that started something called the American Constitution Society for Law and Policy, and it was an attempt to try to counter the Federalist Society. And it has had some success. It's not nearly as well funded and as ubiquitous on campuses as the Federalist Society for a whole host of reasons, but it has had some success. But again, the progressive community, we all march to the beat of different drummers. And so that's a whole other book I could write about trying to, and David could probably write it with me, about starting up an organization and the challenges you face. And so the answer is yes. I will say one good piece of news about the Federalist Society. I don't know if people noticed, but George Conway and some of his compatriots have started an alternative to the Federalist Society because the Federalist Society, they believe, have strayed so far from the sort of basic tenets of American law that they believe Republicans need to take it back. So that was sort of a good news piece to me. I thought, well, maybe there is some notion that there's a more moderate stream of American lawyers who believe that the law has been turned on its head by some of the far right.
And how is the Biden administration doing in terms of appointments?
Amazing. Really great. I think they've done an incredible job against really, high odds. But I think they've done, I give them high marks for their rate of judicial nominations. Wouldn't you agree, David? Alfonso, I'm sorry.
I always get that. I have 2 first names. Yes, I think the administration has done a good job in getting more folks on the court. But again, I think that we confront this narrative war because you have the Supreme Court, and that's what people focus on. And they're not focused on the federal judiciary as a branch and the magistrate judges and the district court judges and the circuit court judges, because the narrative of the Trump administration was, we've changed the judiciary, we have packed the courts, game over. And the game isn't over. It's a lifetime appointment, but, people retire. People don't live forever. So I think the Biden administration has done a good job in making sure that we fill those appointments, despite the challenges that we face currently in the Senate.
Questions? Any more questions from the floor? Okay. So we started talking a little bit about where people sign up for the fight. But Jeff, you particularly made the point about, we talked on an earlier call about green shoots. But what are the places where we should feel some agency that you know of, where we're having some success at creating the, being able to focus on the communities that are important using the confines that we have, and people should feel like all is not lost here?
Right, so I'm old enough, and I look around and there's a generation of us, and you sort of wonder who's coming behind us, and I think there's a lot of promise there. And I think when PrEP came along, we've heard the data about the disparities, but when PrEP was first introduced, It was a group of young black gay men that I was aware of that were doing all the community mobilization. This was often unfunded, but there's a whole cohort of leaders. There's a group called YBGLI, Young Black Gay Leadership Initiative, and these kids at the time were in their 20s, well now in their 30s, and they're doing great things. There's an organization in Riverside, California called True Evolution, founded by someone when he was 17 years old, and now he's in his early 30s, and it's a $20 million a year organization. They just opened a campus of 9 buildings providing transitional housing to people with HIV and LGBTQ people. That generation of people amaze me. There's a whole cohort of young trans leaders that 30 years ago there were far fewer. And I think we need to look to them and also give them space to demonstrate what they can do for us.
And Alfonso, we've been talking a lot about them and they and the allied arrayed forces, but there's a name that seems to keep coming up over and over again in some of these efforts. Edward Bloom. American Alliance for Equal Rights is one of the groups that I think he's been behind. Can you just explain to us the role of kind of who the groups are and the individuals that people should just maybe do some Google alerts so they know what they're up to?
So it's interesting because these organizations, when you look at the name, it seems really innocuous. The American Alliance for Equal Rights, the Wisconsin Society for X, the This Society for Y. And it seems fairly innocuous, but they have a similar sort of narrative and they have a mission. And their mission is to completely remove, one of their missions is to completely remove race as a factor in all laws and policies. So again, it's not just about entrepreneurship, it's not just about MWBE, it's not just about employment, it's about every single factor where race is considered. And so what they've done, and Edward Blum is the person who was effectively, some would say responsible, I would use a different word, but some would say responsible for the striking down of affirmative action in education. And he has funded these campaigns for a very long time. He's wealthy. So he has funded these campaigns through organizations to challenge statutes, regulations, policies that try to advance equity. So in addition to our lawsuit, where his organization has filed a claim against the Fearless Fund, he also sued 2 law firms. They recently brought a lawsuit against West Point because West Point was excluded from the affirmative action decision because it's an institution that focuses on advancing military careers. And he's filing other lawsuits. And ultimately, the goal is, how do I throw as much as I can up on the wall and I see what sticks? That's the strategy. And I will sue as many people as possible in as many districts as possible to see maybe I'll have a conflict. So maybe one circuit says one thing, another circuit says something else, and boom, I go to the US Supreme Court. And I say, Court, here's the question. We want you to certify, we want you to review, and tell us whether or not this indeed should still be the law in this country. And so we should all be concerned because it's a very coordinated campaign to really strip away protections that marginalized people have.
Edward Blum, B-L-U-M, just in case you're Google searching. Okay, thank you. This has been a really good panel. I want to thank you all for being here and engaging. I want to thank Dr. Rocky Moore Cummings for having us here. Thank you for helping to put this together in the entire center. And of course, Johns Hopkins University for giving us this platform and this space. So thank you.
All right, thank you so much for a robust fireside chat. I have been enjoying the panel and the fireside chat that we've had this morning. We want to, before we move on with the program, we want to take a 5-minute break and come back within 5 minutes, and then we'll get started with the next portion of our event. So let's take a 5-minute break. All right, so let's make sure everyone's back on time because our keynote is here. So make sure you're back in 5 minutes. All right. Let's get back. Let's come together. So at this time, can I have everyone in the room take their seats, please? Can we get people to take their seats, please? Daryl, can you usher them to their seats, please? Can we get those to take their seats, please, so we can start? All right. So at this time, it is my distinct honor and privilege to introduce to you someone who never stops inspiring me as a true colleague and friend. Dr. Keisha Pollock Porter is the Bloomberg Centennial Professor at the Bloomberg School of Public Health and the chair of the Bloomberg School Department of Health Policy and Management. She's an injury epidemiologist and policy researcher who serves as the director of the Institute of Health and Social Policy. Her research focuses on health equity and promoting safe environments. In 2023, she was elected a member of the National Academy of Medicine. Please join me in welcoming to the stage Dr. Keisha Pollock Porter.
Good morning, everyone. And thank you for the introduction, Roland. I'm thrilled to be here today to introduce Congresswoman Maxine Waters. Who among us can boast a career spanning more than 6 decades, encompassing diverse roles from a garment factory worker and telephone company employee to a dedicated educator, Head Start program manager, aide to a city councilman, service in the California State Assembly, and representation of the illustrious city of Los Angeles in the United States House of Representatives? None other than Congresswoman Maxine Waters, a true legend, icon, and a force for change, who stands alone in her life experiences an unwavering commitment to compassionate leadership. A graduate of California State University at Los Angeles, she holds a distinguished place among the most influential women in American politics today, and have become known for being a fearless advocate on behalf of women, children, people of color, and the underprivileged. Breaking barriers, Congresswoman Waters made history as the first woman and the first African-American chair of the House Financial Services Committee. She is an essential member of the Congressional Democratic Leadership, the Steering and Policy Committee, and the Congressional Progressive Caucus. What might not be widely recognized is her dedication to health-related causes, and one of the reasons she's here today. As a member of the Medicare for All Caucus, Waters also serves as the co-chair of the bipartisan Congressional Task Force on Alzheimer's disease. Today, we gather here in recognition of Congressman Waters' pivotal role in spearheading the development of the Minority AIDS Initiative while serving as chair of the Congressional Black Caucus in 1998. This initiative was a response to the alarming spread of HIV/AIDS among African Americans, Hispanics, and other communities of color. Under her continued leadership, as we've already heard today, funding for the Minority AIDS Initiative had grown substantially from an initial appropriations of $156 million in fiscal year 1999 to over $400 million annually today. In November 2022, Congressman Waters was reelected to her 17th term in the U.S. House of Representatives, securing more than 70% of the vote in the 43rd Congressional District of California. On behalf of the Johns Hopkins Bloomberg School of Public Health, Department of Health Policy and Management, and the Center for Health Disparity Solutions, please join me in expressing our profound appreciation for today's exceptional and dynamic keynote speaker, Congresswoman Maxine Waters.
Thank you very much. Hello, everyone. I am so delighted to be here, and I'm very pleased that we were able to get off the floor in time for me to come and share a few minutes with you. It was an unusual day. We expelled someone who needed to be expelled. Santos is gone, no longer there. And so thank you for having me here today. I'm so honored to join you all on World AIDS Day 2023, the Minority AIDS Initiative at 25. I'm so proud to have created the Minority AIDS Initiative 25 years ago, and I'm proud to be working with so many of you to expand and improve this historic initiative. So I have some people to thank. Dr. Darrell Gaskin, Director of the Johns Hopkins Center for Health Disparities Solutions; Paul Kawada, Executive Director of NMAC, formerly the National Minority AIDS Council; Nicole Austin Hillary, President and CEO, Congressional Black Caucus Foundation; Marco Davis, President and CEO, Congressional Hispanic Caucus Institute. I also thank Joe Wong Ra-Kalto, Director of Strategic Partnership and Policy, whom I've known since the days when he worked for my dear friend, Congressman Barney Frank. Give Barney Frank a big round of applause. I congratulate the entire NMAC team for being on the front lines of the struggle against HIV/AIDS since 1987. I deeply appreciate NMAC's mission, which is to lead with race to urgently fight for health equity and racial justice to end the HIV epidemic in America. I'm also very proud to have worked with Dr. Maya Rockamore Cummings. Cummings wrote her dissertation on my efforts to create the Minority AIDS Initiative, and she focused attention on the difficulties that Black-led HIV/AIDS organizations have faced trying to secure federal funding to serve Black communities. So, ladies and gentlemen, race has always been an issue in the HIV/AIDS epidemic in the United States, even before anyone was willing to discuss it, and the impacts upon Americans, African Americans, have been especially severe. Let me just say, while I pinpoint and identify the difficulties that race plays and have played on HIV, this is America, you all. And race has been an issue not only on HIV/AIDS, but every aspect of our lives historically. So we know we're struggling always. We gotta fight. By 1998, the year that I created the Minority AIDS Initiative, new AIDS cases among Blacks already outnumbered new AIDS cases among whites. Specifically, there were 21,752 new AIDS cases among Blacks in 1998 and only 16,118 new AIDS cases among whites. New AIDS cases among Hispanics were not far behind at 9,650. Racial and ethnic minorities continue to be severely and disproportionate impacted by HIV/AIDS today. Black Americans now account for 40% of new HIV diagnoses and Latinos around 25%. Asian Americans, Native Americans, and persons of multiple races account for an additional 6%. Likewise, the CDC reports that in 2021, HIV claimed the lives of approximately 8,300 Blacks, 3,500 Hispanics, and 5,000 whites. Minorities now represent the majority of new HIV diagnosis, people living with HIV/AIDS, and death among people with HIV/AIDS. In fact, the rate of new HIV diagnosis among African Americans is about 8 times that of whites, and the rate among Latinos is about 4 times that of whites. Black, gay, and bisexual men face especially high risk, accounting for more than 9,000 new HIV diagnoses in 2019. Furthermore, Black women account for more than half, 55% of new HIV diagnoses among women. So regardless of the statistics, the important thing to remember is that every new HIV infection in the United States is a human being who needs to be screened, retained in medical care, and virtually suppressed. That is the only way we will be able to stop the spread of HIV and save lives. I began my work with HIV/AIDS during the 1980s while I was in the California State Legislature. Ladies and gentlemen, I don't know how many of you know this person, but one of my heroes is Archbishop Carl Bean, who founded the Minority AIDS Project in Los Angeles in 1985. The Minority AIDS Project was the first community-based HIV/AIDS organization established and managed by people of color in this country. Carl Bean, at that time, introducing me to what was really going on with HIV/AIDS in the Black community. He took me to a place called Catch One in Los Angeles, which was owned by Jewel Thias Williams, and introduced me to several young African-American men who were abandoned by their parents due to their diagnosis, had no place to live, and literally was hanging out at Catch One and living in the backyard of Catch One. After the meeting, I had an opportunity to go to the community and discuss what I had experienced and what I was learning about HIV/AIDS. I had organized also something called the Black Women's Forum, and I worked with a number of organizations called the Brotherhood Crusade that was basically led by Danny Bakewell. We both had some money, little money, in our accounts, and I contributed $10,000 from Black Women's Forum, and Danny Bakewell contributed $10,000 to the Minority AIDS Initiative with Reverend Carl Bean. So you could see they didn't have very much, and we did everything that we could to gather small amounts of money to support what Archbishop Carl Bean was doing. So during my time in the California State Legislature in the 1980s, I worked with Carl Bean and other AIDS activists in the Black community to ensure that organizations serving African Americans living with HIV/AIDS would have funding. I also worked with someone many of you know, Dr. Wilbur Jordan, who established the Oasis Clinic for AIDS patients in South LA, basically at the Martin Luther King Hospital. I want you to know he became an AIDS activist following his HIV diagnosis in the early 1980s and went on to establish what is known as the Black AIDS Institute. After I was elected to Congress in 1990, I organized the first meeting in the House of Representatives where issues concerning HIV and AIDS were discussed pertaining to minorities. The Black Women's Forum, an organization, again, that I co-founded and supported, we also supported the Drew University HIV mobile testing project by contributing a little amount, $25,000, to the initiative around the mid-1990s. Drew University HIV mobile testing project is run by Cynthia Davis, and we're pleased that this project is still alive in the Los Angeles community. I want to tell you about a man who I think contributed mightily to the movement that was taking place. Mario Cooper was one of the first Black leaders in the national level to bring attention to the impact of HIV/AIDS in the Black community in 1996. As a board member of the Harvard AIDS Institute, Mario Cooper began a national campaign to increase awareness of the disease. He boldly criticized leaders of the Black community for failing to take the epidemic seriously and organize a conference that drew about 100 African American leaders in politics, higher education, businesses, entertainment, the news media, medicine, and religion. Mario Cooper was especially effective at linking AIDS activists, gay rights activists, politicians, and civil rights leaders. Let me just take a moment to say that unfortunately, in the Black community, it took a long time to have this discussion. And at that time, we had many ministers who had a lot of influence in the Black community, as they do continually over in the United States. They were condemning HIV/AIDS patients and victims and saying that they were the cause of HIV/AIDS and they were being struck by God. And he condemned people of color who happened to have chosen their lives and whom they love and was trying to live their lives. And one minister in particular was so condemning of those who had chosen and who was trying to live their lives and chosen to work in the Black community to try and help educate. Eventually, I had to say to the Black pastors who were condemning those who were, not only LGBTQ, etc., but condemning them for having perhaps become the victims of HIV/AIDS. Finally, I stood up to them and I said, "You're condemning LGBTQ. Who do you think's directing your choir? Who do you think is leading your church? Who do you think is your musical director?" I said, "You better not try and condemn them in front of the congregation when their back is to your back and they're helping to keep this church together." So it was those kind of conversations that we have to have at that time. I am so proud of all of you and the work that you have done and the work that have been done by some of your predecessors who have changed that narrative in the Black community. And now, finally, we are discussing and working and embracing everything that we need to be doing in order to deal with not only the LGBTQ community, but with HIV and AIDS. And I'm pleased to say that we've got a long way to go, but we've come quite a distance in the work that we have done. But now what we've got to do is some of what I'm going to continue to discuss, and that is we've got to get more money always. We've got to get more resources. We need capital. We need money, and we've got to fight for it. It's not going to come because people understand and they know whatever. Sometimes they think that, oh, they are going to do it. Who is they? They is we, and we've all got to work for it. And don't be absolutely deterred by the fact that the Republicans have offered these cuts in this budget that's before us. We're going to fight it, and we're going to win because that's what we have to do. So continuing with a little bit of the history, I organized a meeting with the CBC with Donna Shalala, President Clinton's Secretary of Health and Human Services, and CBC members, and we said to her, point blank, we want to ask you a question. If what we were experiencing in America was an emergency, and should we be labeling it for what it is, an emergency, and moving this government to do something about it? She looked us in the face and said, "You are absolutely correct." And she went to Bill Clinton, we went to Bill Clinton, and the CBC called for President Clinton to declare a public health emergency to combat the HIV/AIDS crisis in minority communities. Most importantly, we told him we needed money for programs to address the crisis. Now, this is interesting because presidents have a lot of power. President Clinton went to Franklin Raines, a Black man who at the time was serving as the Director of Management and Budget, OMB, to find a way to finance a new initiative. Together, they made certain that the OMB would get it done. We didn't go through the legislature. We didn't go through the House. We didn't go through the Senate. We didn't wait for votes. The President of the United States, Bill Clinton, said, "Franklin Raines, get it done." Give Clinton a big round of applause. Give him a round of applause. So finally, on October 28, 1998, I organized a CBC event to launch the Minority AIDS Initiative. The event featured the participation of President Clinton, Secretary Shalala, Congressman Stokes, who was great on this issue, and Congresswoman Donna Christensen, representatives of HIV/AIDS organizations from all around the country, and of course, I was there. Minority AIDS Initiative and the funding history, just a bit. At the 1998 rollout, we announced that the Minority AIDS Initiative would receive an initial appropriation of $156 million in fiscal year 1999. The purpose of the Minority AIDS Initiative is to target funds for HIV/AIDS prevention, outreach, screening, and treatment to minority communities heavily impacted by HIV/AIDS. The funds were to be provided to minority-led, community-based organizations in order to help these organizations develop their capacity to deliver culturally and linguistically appropriate care and services in their community. Let me repeat. Provided to minority-led, community-based organizations. The Minority AIDS Initiative, we know, is divided among 4 agencies within the Department of Health and Human Services: the Health Resources and Services Administration, that focuses on treatment as authorized by the Ryan White Care Act. HRSA now receives about $170 million per year, specifically for the use in minority communities under the Minority AIDS Initiatives. The Centers for Disease Control and Prevention, CDC, focuses on prevention and testing, receives about $100 million, specifically under the Minority AIDS Initiative. The Substance Abuse and Mental Health Services Administration, that is SAMHSA, received $119 million in fiscal year 2023 under the initiative to do HIV-related work among the minority populations they serve. And finally, the Office of the Secretary received $60 million in fiscal year 2023 specifically for the use in minority communities under the initiative. The Minority AIDS Initiative has strong support in Congress. Last year, I circulated request letters to leaders of the House Appropriations Committee in support of funding for the initiative, and dozens of concerned members of Congress signed these letters. Because of our efforts, the Minority AIDS Initiative now receives about $440 million each year across all 4 agencies. Now, we got to fight for more money. That may sound like, well, that's great from where you started, but it's not good enough. It's not good enough, and I absolutely support the idea that this money has to go to minority-led programs and agencies. It is so important. We have a lot of people who are sympathetic and who help and who work, but they don't know how to deal with minority communities. They don't speak the language. They're not culturally, proficient in what they do because they're doing their best. But hell, when we write and when we talk, nobody understands us but us. Unfortunately, the Minority AIDS Initiative has been compromised by the politics of race. The Supreme Court decision in the 1995 Adirondack case held that the federal government can only use racial classifications if they are narrowly tailored to further compelling governmental interests. The Adirondack case involved affirmative action for minority-owned small businesses in federally funded transportation projects. Last year, the Supreme Court went further in the case of Students for Fair Admissions versus Harvard College and outlawed affirmative action at American colleges and universities. Because of the politics of affirmative action, President George Bush, W. Bush, administration gradually changed the way that it implemented the Minority AIDS Initiative by diverting funds away from minority-led organizations to organizations that serve minorities but are not led by minorities. But the Minority AIDS Initiative is not about affirmative action that is being described in these court cases. It is not about supporting minority business development or helping black students go to Harvard or Johns Hopkins. The Minority AIDS Initiative is about saving lives. It is, and you know, of course, that that's what you do, that's what you've been doing. You've seen many of your friends and your associates have passed because they did not get the care that they needed. And while we all agree that there's been improvement and that we've made gains. We need money, and we have to say the word money. Don't even say funds. Say money, money, money. We need money in order to deal with HIV/AIDS in the Black community. Latina, Asian American, and Native Americans lives matter as well as Black lives matter. We've got to work together, asking for this money, joining hands, and making sure that we get the word to where it needs to go. There can be absolutely no doubt that the federal government does have a compelling interest in saving the lives of racial and ethnic minorities who are severely and disproportionately impacted by HIV/AIDS. There's also no doubt that minority-led community-based organizations can save lives in these communities more effectively because they're culturally competent and understand the communities they serve. And so this is why I've urged President Biden and his administration to redirect Minority AIDS Initiative funds back to minority-led organizations that understand and serve our communities. These funds are a small fraction of what the federal government's overall funding for domestic HIV/AIDS programs, and redirecting them to minority-led community-based organizations will build capacity, improve equity, and help minorities meet the tremendous need in our communities. Now, we got to deal and got to face these budget cuts that are being proposed by the Republicans. It is very unfortunate that the politics of race is not the only threat facing people living with and affected by HIV/AIDS today. The Republican majority in the House of Representatives is slashing the HIV/AIDS funding under a wide variety of federal programs. Their proposed Labor, Health, and Human Services, that is HHS, appropriations bill for fiscal year 2024 cuts $767 million from domestic HIV/AIDS programs in 1 year. It cuts funding for the Minority AIDS Initiative in the Office of the Secretary by 53% and completely eliminates funding for minority AIDS initiatives within SAMHSA. It also eliminates funding for the ending of the HIV Epidemic Initiative within the CBC, the Ryan White HIV/AIDS program, and the Community Health Program Centers program. The cuts to the Minority AIDS Initiative will exacerbate racial disparities, and the elimination of the ending of the HIV epidemic initiative could leave thousands of people without comprehensive care for HIV and tens of thousands of people without access to PrEP, which prevents infections. These programs used to have widespread support. It is shameful that House Republicans are now trying to eliminate all of them. We cannot allow these cuts of Congress to pass. We cannot compromise. We cannot give up. After all that we have accomplished, we must refuse to allow the politics of race to undermine the Minority AIDS Initiative. We must refuse to allow House Republicans to undermine HIV/AIDS programs throughout the federal government and risk the lives of millions of racial minorities and other Americans who are living with or at risk of HIV. The lives of people affected by HIV matter. Ladies and gentlemen, when we was on the floor today, there were two issues. One I alluded to about the expulsion, but the other one was a fight about small businesses. And this was a fight where the Republicans are attempting to basically support the biggest banks in America from having to come up with the kind of data that is necessary to determine whether or not they are discriminating against small businesses and minority businesses, et cetera. And so it got pretty heated. As it got heated, the Republicans got more vocal about their stand and said that we were trying to shame the big banks and that I was just an active Democratic activist politician that was trying to do this shaming. First of all, I claimed the definition. Yes, I'm an activist, Democratic politician who's not only shaming and blaming, but fighting against the kind of protection that they're getting from the Republicans. And I think, while I had a list of several of them who had gotten money from that PPP program under COVID-19, and many of them had gotten it after they had used up the money in the PPP program, and we had to go back and get $60 billion more to give to the small and minority businesses. And so while I have a talking relationship with some of them I don't. So instead of calling all the names, I'll just save them so that I can include them in my talks as we go along on this issue. But I called out one person because the United States will know who she is. I said, Marjorie Taylor Greene got an appropriation from the PPP program. And not only did she get the appropriation, it has now she's been relieved of it because she does not have to pay it back, because the rules say that you can be relieved if you ask for it. So we got to fight, and we got to fight dirty. And that's not a bad word. It's a good word when you're fighting dirty people. And so I want you to know we cannot resist the fights that we're going to have between now and January when we take up the budget. We're just working on a continuing resolution to keep from shutting down the government at this time. But the stuff is going to hit the fan in January, and we got to be willing to fight. It has not just been, on the social networks to talk about how bad they are. You got to come to Congress. You got to jam the halls. You got to knock on the doors. We've got to get everybody, all of the members who support us and support the funding for HIV/AIDS, not only to put it on their social networks, but to speak about it on the floor. We've got to carve out more time, the 1 minute and the 5 minutes. We've got to do it over and over and over again. And you can't have too many activities on this issue. Whether or not you're, blanketing the halls of Congress, or you go to a restaurant nearby and we continue, maybe we need to do something 24 hours around the clock, where we're doing something in Washington, D.C. to draw attention to what is going on and telling people who are in earshot to come on, join us. We've got to be activists. But I don't know why I'm saying this. You are activists. And I don't know why I'm saying this to those who understand, those who have sacrificed their lives for justice and equality all throughout the civil rights movement, all throughout every issue that you can identify in this country where we've been trying to get justice. Because we know about this. Sometimes we don't do everything that we could do, but we should rethink it. And think about, I'm going to renew the commitment of my grandmother and my grandfather and the people who sacrificed for us to have justice and equality. And so I don't want Democrats to be nice because the Republicans don't give a damn about the rules. They change the rules in the middle of the game every time. And it doesn't matter what they are targeting. They find new ways to undermine. That fight that I had today on small businesses, that was taking on Chopra over at the Consumer Financial Protection Bureau. They hate him because he's a good director fighting for consumer protection for people who didn't have it before we did Dodd-Frank Act. And so they're going to be dirty. They're going to fight in every possible way that they can. But one thing that cannot happen to us, we can never be intimidated by anybody. We can't be intimidated, and we must be willing to put ourselves on the line. And I emphasize this because this new speaker that we have is a right-wing conservative who supports Trump and was one of the lawyers who tried to help Trump prove that the elections was a fraud and that he should be president. So don't think because they have a new speaker in the House that anything different is going to change. He's going to be smart, he's going to be slick, and he's going to use everything in his power to try and get the budget that they want. But we in the Black Caucus, in the combined caucuses that's in the House of Representatives, we're going to be there on the front lines with you, doing what I'm advocating in order to make sure we get America to do the right thing. We started out with this amount of money. It's certainly not nearly enough, and we have to keep the struggle going, and we've got to be loud and clear about it. I'm with you. I ain't scared of anybody. I don't know how to do anything being scared of anybody. I came from a huge family in St. Louis, Missouri, with 12 siblings, and we didn't do anything but fight all the time. And so I was reared and socializing on fighting and cussing. Thank you very much for having me. I appreciate your inviting me time and time again. I consider our relationship one of the best that I have had organized in my career, and I consider our work one of the more successes that I've had. There's a lot of things that perhaps we need to pay attention to, and I would like to gain some success on, but I have pride in the work that we have done together on HIV/AIDS. Thank you. Thank you. Thank you so much. You're welcome. Let's do it.
Let me close out real quick. All right. Wow. Wow. Thank you so much, Congresswoman Maxine Waters, for gracing us with your presence and your wisdom. It certainly has been a privilege to me, and I suspect I could say for everyone else as well. I want to close by saying thanks to the entire Hope Challenge team. We could not have got any of this possible without you. Please join me in a round of applause to the Hope Challenge team. And also for the generous funding from the Nexus Award and the Richardson Professorship. This is only the first. This is the beginning of a series of events that we're going to be focused on leveraging public policy to address preventable health disparities. Now, I need your help with one thing. I need your help with two things. One, I need you to go fight, like what Congresswoman just said. The second thing I need is that we're going to send you a survey in the next couple of days. Please fill it out for us. It affords us the opportunity to make our events much more stronger. But I think we started off in an outstanding place, So lastly, I want to say thank you for your time, and on behalf of the entire Hope Challenge team, thank you for your time. We wish you safe travels to your next destination and a very pleasant and restful holidays. Thank you.
Let me take a moment.
Yes, yes.
With me today is Kathleen Seinstock. She is a very quiet member of my staff who works around the clock on this issue. This is one of the issues that she prefers to work on. When I try to get her to work on something else, she always claims she's got to do something on HIV and AIDS. Kathleen Seinstock, where are you?
Right here, right here.
Oh, there she is. Give her a big round of applause. Yeah, sure. You want to take some photos?
Yes.
Okay. All right. Thank you.